apart from VO2, your ability to be metabolic flexible defines risk. The people who were eventually able to survive were the ones who were able to change those specific substrates. If one was constantly only relying on carbohydrates, those were the ones with poor outcomes. Created a huge amount of flow in the brain, like they would, for instance, sprint to a house and need to be ready to clear that house. Thus, their breathing skills or non-skills, because they didn't train them at all, have influence on their brain function, the flow.
Is your utilization, your mitochondrial dysfunction, then you're training your heart, you're training the wrong thing because your heart's already supplying more than the muscle can use.
Delivery is no issue, yeah, absolutely.
And so you're improving delivery in a system that already has an excess of delivery. All right. Hey, so thanks for joining, by the way. I really appreciate you coming on. It's rare for me to meet someone who knows more about VO2 max data than I do. And so when we started talking, I was super excited to kind of have you come on and teach me and hopefully teach all of us some things about this really remarkable data. And it's not just VO2, of course. Maybe you can just go through and tell us a little bit your background and what Splendo's doing, and go from there.
Right. No, absolutely. So my name is Jeroen Molinger, and as you can hear from my accent, I'm not from the US. I was recruited by Duke University almost 7 years ago, mainly with my background in physiology with a specific focus on transplant. As you know, that Duke is by far one of the biggest transplant hospitals in the US and also in the world. So my work and my research at Duke is very much aligned with in the ICU, in the intensive care units, also in the preoperative space. So how do you really define the need for, or how do you define the risk profile of patients in a way when they're going for a major elective surgery as such? Or how do you define specifically, how do you optimize them also before surgery from a preoperative perspective? But in the ICU is more or less, how do you define the need for early optimization from a exercise prescription perspective, from a nutritional perspective, all the way up from the post-op ICU and to the floor and eventually discharge. And if you're going back to my whole career, is the kind of my red line, all the stuff that I do and I'm still doing is metabolic card data. So using metabolic card data as a way of really assessing the physiology of a patient or a client or a athlete or potentially also a special force operator, for instance, special operations operator. So where it comes into play, where I think is kind of interesting talking about VO2 is, as we'll talk about it later on, as what it really means and the whole kind of robustness of this metric as a predictor of all-cause mortality. But I think it's interesting from my perspective, what I do is that, and I think there's not metric at all that kind of defines the same way, is that this metric can be used in any space. If you are this metric, if you're in the high side, then you're looking at performance. If this metric on the low side, then you're looking at risk. It's the same metric. There's no other metric that we know of, like cholesterol, like blood pressure, whatever. That doesn't tell you the specifics on the high and low and where you're at right now. And I think there's a lot of, I would say, fuss and a lot of hype around VO2 currently, I think, and that's a good thing. I think the last, would say, 3 or 4 years or so, it was really increasing the knowledge, but also I think people want to measure and assess that. But again, also I want to make the case that as much I am a very large favorite and advocate of assessing VO2, the metric of VO2 itself is only 20% of the whole story.
What do you mean by that?
Good. So if you want to have your VO2 max tested, and I think someone kind of relines that based on the science, that we know that that specific number defines potentially how you are based on your peer group, your percentiles, is not a pass-fail test. It's a test that defines your physiology at that given time. And that given time physiology or your performance or your risk profile needs to be kind of deep dived in to see what makes that number high or low. What are your specific limitations of this specific VO2? So, and then I'm not sure if I'm sure you know, but I'm not sure if the audience knows. But if you're going back to kind of the physiology of how VO2 was kind of invented, or the first that was published on, that was Eugene Adolph Fick, a scientist in the 1900s, that saw that VO2 as a metric of oxygen consumption, and make sure that we are only measuring it as from the mouth. So it is kind of a black box metric of overall mitochondrial respiration. You have really no clue which specific mitochondria you are assessing. Of course, you have a clue when you're combining rest versus exercise. And exercise, of course, you're measuring mainly that tissue that has the highest oxidative capacity and has high oxidative demand, hence the muscle.
Right.
But also your VO2 in rest is defined by your brain, by your gut, by your kidney, by your liver, by your muscle,
Right.
of course. So there's a lot of stuff that kind of defines the specific utilization of oxygen also in rest. And what Eugene Fick kind of acquired based on his science in that time is that VO2 is the number. VO2 is defined as your ability to deliver, and delivery O2, DO2 is your cardiac output. Your cardiac output is your heart rate multiplied by your stroke volume, and that cardiac output multiplied by your oxygen AV-diff. And oxygen AV-diff means the A stands for arterial, V stands for venous. So if you are able to measuring what oxygen goes into the system, so the highest oxygenated blood that's just coming from the lungs, and then also compare that with the lowest oxygenated blood going through your system and is entering the lungs. So that's your highest mixed venous measurement. So that extraction ratio multiplied by your delivery, that will give you the number of VO2. So going into equation,
just to pause there, I think, because again, you and I maybe are so familiar with the physiology that we have all these mental models in our head, but even some of the terminology, I think, can be useful to go through. So stroke volume is the amount of blood pumped by the heart on each beat. So when it squeezes, how much volume of blood does it push forward? And then, of course, the number of squeezes per minute times that volume is the total volume that your heart pushes forward into the system in 1 minute, and we call that as cardiac output, right? Then we say, okay, that heart, the blood that your heart is pumping to the system from the left ventricle to your body, brain, is highly oxygenated, coming from the lungs. Goes to the body. Your body uses that oxygen for, as you said, mitochondrial respiration, for basically metabolism, the production of energy from various substrates, fat and oxygen. We're going to get into, fat and carbohydrates. We're going to get into all of that. Then that oxygen has been subtracted. So the blood returns in the venous system back to the heart, the right side of the heart, in a less oxygenated form. Right? Goes then back to the lungs, and the lungs re-oxygenate it. That's their part of their. That's one half of their job. Getting rid of carbon dioxide is the other half.
That's the whole circle. Yeah, exactly. And it already
so that difference, then the difference between that highly oxygenated and low oxygenated, when it goes away, when it goes out, and when it comes back, is the VO2, right?
Yeah, exactly. Yeah. So I would say kind of if you're looking at the as a comparative of a car, kind of the gas you're putting in and the exhaust fumes you're getting out, those differences there. What do you use and what goes in there? I think it's kind of a good kind of overall look on how cardiac output kind of defined, because that's one of the I would say the longest, I would not say myths, but there's a lot of discussions in our physiology world about A.V. Hill. And A.V. Hill was a scientist in the early 1900s that showed the VO2 plateau that defines max. Again, if we go back, we have VO2. And you can say you have a VO2 max or you have a VO2 peak. And the difference between the two is that the VO2 max is defined as your VO2 being on a plateau. It means it goes up and it plateaus. And that specific plateauing measurement, that will be your VO2 max.
And that going up is in response to exertion, right? In response to
Demand.
demanding more. So you're on the treadmill, you're on the assault bike, you're demanding more oxygen for higher metabolism,
Yep.
and then that VO2, the consumption of oxygen goes up and up and up, and then plateaus at some point.
That's your point. Exactly. That's what also Eva Hill proposed in his our science from the last century. Currently, we are right in the middle of writing a big three-piece publication with a lot of very high scientists from the world in kind of debating of debunking the Eva Hill kind of proposal. And I will show you a little bit on, I think, why it's not specifically the case. Eva Hill said that the main limitation of anyone looking at VO2 max as the plateau of the VO2, that can only be derived in a very well-defined protocol when you're constantly increasing the resistance, so increasing the demand, which eventually will give you that specific plateau on the end. And that main limitation of that demand was mainly your cardiac output. And so delivery, in a way, not your oxygen EV diff, not your extraction ratio, but your delivery was the main limitation of VO2. And I think that's a thing that's already going around predominantly, I think, in the science. And looking back in what the science in the early in the last century kind of gave us, was a very small cohort of subjects. So there's a lot of debate if that's truly the case. And I want to make the case for the stuff that I do myself, and I will show you later on the modalities that we use to really assess VO2, that you can even have a VO2 max, not as a very profound REM protocol where you're doing a 10, 12 minutes kind of a workup, but in a 1 minute allowed test on the air bike, which you think that's kind of ridiculous. We do it's almost a double wing gait, right? When you have that 3 seconds, 50 seconds of allouts, is able to also mimic that specific plateau in the last 20 seconds of the all-out test. So that kind of redefines the plateau as purely being a limitation of cardiac output or stroke volume or heart rate, right? So a little bit going back to your kind of your framework and how that specific defines as your cardiac output and your heart rate. You can already imagine that if you're only looking at cardiac output as the main limiter of VO2, let's start with that. Let's say that's the case. Then you have to go back a little bit. What is defining cardiac output? What are the other influences on the system right now that defines cardiac output? And then you have to look into the left and the right side of the heart, because people think cardiac output is only looking at the left side, but also the right side has a very important function there. It really pushes out the low oxygenated blood, so the mixed venous blood, from the heart to the lungs, to make sure that the whole pulmonal perfusion is optimal. You can imagine if that pulmonal perfusion, so the delivery of oxygen through the lungs, is somewhat impaired, that can have huge consequences for the diffusion capacity of the lungs itself. That itself, you would think, and that was kind of the way that we would think as a pathophysiological impairment, looking at the major, or looking at RDS, looking at COPD, looking at potential heart failure, looking at pulmonary hypertension, all those specific impairments, what kind of defines your inability to extract from the lung itself, is also seen in healthy people doing maximal high intensity exercises. So it's not specifically when you're having a issue at all. It can potentially just a physiological limitation of the lungs itself. Really goes a little bit in depth. Yeah, go ahead.
Yeah, so that's kind of interesting, right? I mean, like we laid out earlier, kind of this system, right? The heart, the left side of the heart pushes blood forward, oxygenated. The muscles use it, send it back deoxygenated. The right side of the heart then pushes it back to the lungs, right? The lungs return it back to the left side of the heart, and there's that figure eight kind of loop.
Yep.
And at each point, it seems like you could have a limitation that would then be the limiting factor of your VO2 max. That could be delivery. Your heart's not able to pump. Your blood vessels, for whatever reason, aren't able to deliver. It could be utilization. Your muscle's not very efficient or very good at using oxygen, so it doesn't extract very much. Or then the limitation could be your right side of the heart's not able to either deliver, or your lungs not able to uptake, either one, again, kind of mimicking exactly the left side is okay. On the left side, it's delivery and muscle use. On the right side, it's delivery and lung function, lung exchange, gas exchange. And so each one of those, whether it's delivery, utilization at the muscle, delivery on the right side, or gas exchange at the lung, any one of those can be a limiting factor of your VO2 max, basically?
Yeah. So
okay.
let us go a little bit through the system itself, and let's start with that specific first step: blood going through your right heart to the lungs.
Yep.
One of the things that we do, for instance, at Duke in the cath lab is called a right heart cath. So we do a catheterization of that right heart, and we can measure specifics in that right side of the heart, mainly, for instance, pressures. So if you would have a heart that needs to push into a very, let's say, rigid lung system.
And so just to jump in, we're putting a pressure transducer physically through the venous system into the right side of the heart. It's a physical transducer in the right side, right?
Yeah.
And then we're getting pressure information.
Exactly. So so we do that also in rest, but also during an exercise.
I've never seen one in exercise.
Invasive exercise testing. So what you can then predict is to see how the heart is responding when you're really asking something of that. So there's a demand when you're doing a treadmill a bike, supine or upright bike test, to see how those specific pressures changes. And those specific pressures changes can give you an insight if there is an issue in the lung, or is there an issue in the heart? Is there a very stiff heart? Do you have issues with preload? And preload means how much. So the heart is a kind of interesting muscle. If you look at the muscle, for instance, the biceps is also kind of in a comparative. So a muscle works the best when the muscle is kind of stretched out.
Mm-hmm.
And in that stretched out, there is a kind of a optimal stretching of that muscle. And if you overstretch it, it cannot contract. If you understretch it, it cannot contract. So there's a kind of a sweet spot in the middle. And that sweet spot is the same in the heart. So if you kind of have a larger volume in the heart, it's called the Frank-Starling curve. And Frank-Starling means the higher stretching you have on the cardiac myocytes of the muscle of the heart, the more the heart can push. The harder the heart can push, so eventually it will create a larger increasing of stroke volume.
And I think most people have that experience, right? If you go to the gym and you're doing like a pec fly or something like that, right? Yeah. It's hard when you're here, and it's actually pretty hard when you're here. Yeah. But in between, it's a lot easier in this kind of middle range, right? Yeah. And that's because the muscle is actually a little bit stretched, but it's not too stretched. And then, of course, it gets very hard at that extreme stretch. The heart's the same way, right? So when it's more full of blood up to a certain point, it can push harder. But then if it gets even more full, then it's overstretched and can't push as hard.
Exactly. And that's what happens. Yeah. Both sides can happen. One of the things that we still know, if there is in athletes, if there is a limitation on the heart in athletes, the main limitation on the heart is called the end diastolic volume. And end diastolic volume means if you have your diastole, right, that's in rest. So the last minute of rest, when you have a transition from rest to contraction. So the heart is filling up, is ready to make that contraction, that largest amount of volume.
Yeah.
So if you can increase that, then you have a larger output. So the reason why they think that end diastolic volume is such a good predictor of VO2 max is that one of the what's called the traits of an athlete is also having a larger amount of plasma volume. So your circulating volume in your system is increased. Hence, you have the ability to have more volume inside your heart. Also, we can debunk that later on, or what are the specific responses when you can change VO2? One of the VO2 potential metrics that can change is a increased circulating volume of plasma. So more plasma means more circulating volume, increase also cardiac output. And we can talk about later in how we define the heart, lung, and also with the muscle. But a little bit going back from the heart, from the, let's say, the right half of the heart pushing it to the lungs. So we call that Q. Q stands for cardiac output. The V stands for ventilation. So if you have some kind of a mismatch, that means if you have a lung that's being ventilated and you have so there's a capillary, that is, you have an alveoli and you have a capillary that meets it, then you have ability to exchange CO2 coming in, CO2 coming out. So if there is a kind of a mismatch in this ratio, we call that ventilation, VQ, ventilation, cardiac output mismatch, VQ mismatch. If you're looking at the lung itself in rest, and let's make it very easy. We have an upper part and a lower part of the lung. So the lower part of the lung that has a lower amount of ventilation, but based on the gravity, that is where the most of the perfusion, most of delivery of oxygen is still being there. The upper part is all the way around, where you have a lower amount of perfusion, lower amount of blood going through, but a higher amount of ventilation. And that's kind of in rest. When you do an exercise, it's going to change. So there's based on your heart rate increase, there is a lot of blood flow, pulmonary blood flow increasing to that specific state. And what eventually will happen is, if that VQ mismatching means if you have a region in the lung which has a low ventilation but a high perfusion, and it means that you have deoxygenated blood not being refreshed by the alveoli, but still passing through, and eventually will mix in the end on your left side, on your left side of the heart, then you eventually have a decrease of your oxygen inside your system, and that's called shunting.
The extreme example that comes to my mind, of course, is a blood clot in the lungs. If you just have a blood clot in one of the arteries, well, no blood is going there, so the lung may be inflating. It may has oxygen there, but whatever, but you're not going to get any oxygenate, any blood flowing through it. That's a decrease in perfusion. Now, by contrast, if there's no problem with the artery, but the lung is collapsed for some reason, whether that's let's say pneumothorax or anything, where that lung doesn't have any air in it, but it's getting blood flow. In either of those two situations, there's going to be a mismatch between the flow of blood, perfusion, and the gas exchange, that should be happening, right? And so, those are kind of the disease states that kind of highlight maybe this. And this term shunting, it took me a long time in med school to understand shunting. Actually, just this notion that blood is the collapsed lung example, maybe to me is the easiest to understand. Is blood is flowing, there's no oxygen there, so the blood returns back to the heart just as deoxygenated as it started, at least from that part of the lung. And then it's not fully refreshed. Blood coming back.
So you're ending up again. I also make kind of the comparison with a car and gas. You're for instance, you're starting off with an octane of 92, and then you're at the end you have a octane of 82, which normally should have been refreshed by 92, but you still have 82, then kind of combined with 92 because you still have some oxygenated blood there, but eventually your arterial oxygenated oxygen pressure will decrease. And again, the thing is, we talk about this because already people who know this is mainly from a perspective of illness, right? Not as a perspective of this just physiology. And that shunting has a specific name. It's called intrapulmonary arteriovenous shunting. And that shunting is also so what happens then if blood comes through the system right now, and you're pushing really hard. For instance, you do that one minute aloud. This I think is a good example. You're pushing really hard. So there's a lot of respiration going, a lot of ventilation going. There's a lot of demand. Demand is increasingly high because after that 30 seconds, all the systems are on high alert. Your demand of delivery, your demand utilization, every system, the heart, the lung, and the muscle are really screaming for, give me more somehow. And then you kind of see, am I able to give more? Or is some system kind of lacking and I need to kind of compensate it with another system? If that happens, one of the things, and that's the delay of the hemodynamic system, the heart and the stroke volume, that kind of sets in after 30 seconds because also heart rate is a very slow kind of metric. It also has a kind of a delay. So the drift will be a little bit later on. So after that, let's say 20, 30 seconds or so, then you see a significant increase in heart rate. And if that happens, the system wants to make sure that cardiac output is maintained. And doing that is to kind of decrease your afterload. And afterload means where the system needs to push into. So your left side of the heart pushes out and gives it all that new blood to the system right now. If that needs to be pushed against the pressure gradient, that's tough to do. If the pressure gradient is low, then perfusion of the muscle, because you're doing a lot of muscle work, will be much more easy to do that. And to get that afterload less is creating shunts. So what you're doing is right now, you have for your life, for instance, over there was, and you have a capillary coming here. Then you have kind of a, we call it an anastomosis. So then you have a kind of a bypass. So a part of the blood goes through the alveoli, and part of the blood kind of bypasses it and kind of creates less pressure. It decreases pressure. Eventually also have the ability to increase end diastolic volume to make sure that cardiac output is always maintained. But that is only from a cardiac output perspective. It has huge consequences of your VQ mismatching. And VQ mismatching means that you have a potentially lower ventilation and then higher perfusion based on, because you're mixing that shunting piece. That can have yeah.
I've never heard of this. This is actually super interesting because you're right. I've only, in medicine, we only come from a illness standpoint, right? We don't consider exercise, the exercise adaptations or the exercise effects. It's not really taught. But so you have the capillary here, and then you have the alveoli that's kind of right up against it, and gas is being exchanged across that boundary.
Right.
And so you're saying that if you increase the flow through the capillary so much, some of that blood is being exchanged, but maybe some of it on the top side of the capillary is just bypassing, and so you get an effectively you get a shunt.
No, it's even before that. So there is already kind of call it a bifurcation of the blood flow even before it reaches the alveoli. That's the interpulmonary shunting what you can create.
I see.
That shunting creates a decrease in the overall pressure in that system, and that system is also the system that creates your afterload. So if you can decrease that, then the amount of, let's say, the amount of work that the right heart needs to do is less, because there's less pressure there. You can have a higher throughput, but that will have consequences, because you will not utilize all the blood volume going through the lungs to be oxygenated. That's one. And I think the oxygenated piece is not the most important thing. It's because we are very capable of, we call it transit time. That means how fast can blood flow through the alveoli, and how fast can air come into the alveoli, contact to each other, and have that kind of diffusion, right? That's very quick. So we have it needs 0.75 seconds to 0.25 seconds. So this is a very, very fast way of doing that. But there is another but there. If you are, and that's the dysfunctional piece, if you're looking at the breathing itself, so if you are hyperventilating, which eventually you will be, and hyperventilating during exercise, and mainly, again, I'm looking for the 1 minute allowed, because that's a so defined hyperventilating kind of modality. It's that hyperventilating will mean that your alveolar oxygen tension, we call that the P big AO2, versus your P small AO2. A small O means O2, and E stands for alveolar. We call it the A gradient. Is the difference between those two. If you can extract, so that's what we see in our metabolic car data. We cannot measure, we can kind of calculate it, but we cannot measure directly. One of the ways of measuring it as an efficiency marker is if you're comparing your inspiratory fraction of O2, literally what you're breathing in through your mouth going through the lungs, and what you're breathing out. There should be a delta, right? You should extract some of the oxygen, so there should be a less fraction. And again, the fractions can go, a little bit depends how good or how bad your breathing habits are. You potentially can have a delta of 7. So that means that you have your fraction of expired can go all the way down to 14, 15%. But also, when you are in a hyperventilated state, the time that the O2 in the alveoli goes back and forth is so fast that the diffusion can potentially be impaired. But that means that you do not have an oxygenation issue as of yet, but what is more important there, that the CO2 removal is impaired. So you're breathing very hard. Yeah.
That's something also I think most people that I've talked to don't necessarily have, because we breathe and we do it so naturally. It's just living our lives. We don't realize how separate the CO2 and oxygen systems are. CO2 is not hemoglobin bound. CO2 is not, it's a totally different system, right? There's the whole bicarbonate, system there. And so even though it's happening at the same time, oxygen's going in, CO2 is going out, that exchange is happening in the same location, biochemically, they're quite different systems, right?
Yeah.
And so let me try and see if I understand what you were pointing at. So we breathe in 21% oxygen from the atmosphere, let's say, if it's unsupplemented, right? Our body subtracts a certain amount, right? And returns less oxygenated blood. And so as the blood is coming into the heart, into the lungs, it's deoxygenated. And the AA gradient is the difference between what's in the alveoli and what's the blood that's sort of passing by it, trying to pull some, right?
Exactly.
And and the same thing, I guess there's also a CO2 gradient, right? Like there's the CO2 in the alveoli and the CO2 and it's all its forms, bicarbonate, everything. Carbonic acid and all of that is in the blood as it's passing by. And the exchange happens rapidly, but maybe not rapidly enough at certain respiratory speeds.
Exactly. And what it does, it's going back to the shunting piece, that the reason why shunting is potentially very efficient is creating a widening of your AA gradient. And that widening of AA gradient means that your pressure gradient is larger. So your potential diffusion, because you have your transit time is slow, you need to have a larger pressure gradient to make sure that it's easier for the O2 to get in. If there's a widening, but the widening itself from a RDS perspective, for instance, is not what you want to have. So it's a kind of a weird way of looking at physiology versus pathophysiology in a exercising healthy subject going all out versus someone with RDS. And that's kind of the intriguing piece. What I do is kind of combining those pathophysiological stuff that we see on a ventilator patient with RDS versus someone who you have on a metabolic cart who's doing a 1 minute allowed. In a weird way, something is similar.
Right. You could, in a weird way, you're treating almost exercise as a disease state, right? Or the actively exercising state. And there's some interesting correlations there, right? Increased free radical generation, increased inflammation, it is kind of a low level disease. That's fascinating. Okay.
Absolutely. I kind of going back to that specific AA, or mainly looking at how the alveolar fraction of expired O2 is changing by each breath. I want to kind of, there was Peter Thiel mentioned something also in his podcast and also on Instagram, a reel, when he was saying one specific phenomenon he saw. He used the VO2 Master. This is also a wireless metabolic cart, and he saw based on breath hold. And I want to kind of debunk that specific kind of framework, how that physiology works. I think it's a non-physiology thing. It's more a O2 sensor thing. So what he was saying was, when he did an exercise or he did a ramping up of a VO2 Max test, at the last piece, for instance, if you do a 4x4 or whatever, at the last, let's say 20 seconds of the all-outs, you do a breath hold, which is tough because you're already in that high ventilated drive, right? The system needs more, and when you do a breath hold, that's tough to do. When you do a 7 seconds breath hold, that means that you do not have any fraction of expired O2 going to the center because you have a breath hold. That means on the PaO2, your CO2 levels goes up. So your PA CO2 levels goes up, big AO2 goes up, and because you're still utilization of oxygen, so your extraction is still there. So your PaO2 will go even lower. But that is kind of accumulative. That means that you have you potentially, I said, you can have a 5-7% delta. So you can go all the way down from your fraction of expired all the way down to 14. If you do a breath hold, that doesn't mean you extract more, you're accumulating less oxygen because you're doing holding. So you can go from maybe from 40% all the way down to 10%,
Okay.
which is non-physiological. But when you're done ready, and then you breathe again, your O2 sensor is a very stupid sensor. It only measures two things. It measures how much you're ventilating, so the tidal volume and your frequency, your overall minute ventilation, your VE, and your delta. And then it just calculates that. So if you have a large delta based on your accumulation, then it thinks you have an extremely high VO2. He said, I was going for 50 to 60, 65, 70. You don't have a VO2 of 70. It's just based on the sensor itself thinks, because there's a large delta because the normal sensor is only built for breath by breath data, not breath holding. It's merely made a constant kind of a transport of flow. The flow needs to be back and forth. Then you have an O2. So people think, because the reason why I'm telling this, people think there was a lot of people who were kind of saying, this could be the Bohr effect based on my CO2 retention training, right? So one of the Bohr effects means that if you have a high CO2 level on the level of the tissue, hence the muscle, then the affinity of hemoglobin to O2 will be less, and then you have a kind of a push of O2 into the peripheral tissue. That way you kind of have let's say, an augmented utilization of oxygen from that specific tissue. So they thought, wow, you see it, you have a breath hold, you're increasing your CO2, and in 6-7 seconds or so, you will have a push from O2 from the peripheral level to your muscle. Muscle will consuming more, hence you will see an increase in VO2. But in a way that can happen, but not in 6-7 seconds or so, because there's a much more delay there, and it's completely kind of an anomaly of the O2 sensor, or a misuse of the O2 sensor to have those large numbers, because it is really not.
So that's a good point. So again, I think it's interesting. Are you familiar with the Goodhart's law? So it's a term that's used, I think, more in economics, but it says when a measure becomes a target, it's no longer a good measure.
Exactly. Yeah.
And part of the issue is that when we start targeting, hey, how do I increase my VO2, which is fine, right?
Yeah.
Well, if we start abusing the sensor in order to get a higher number, then we're not comparing apples to apples, right? We've just sort of manipulated the device. So these devices, it's important to know, the device measures the volume of air moved in and out, right?
Yep.
And it measures the concentration of oxygen in that air,
exactly.
right? And so if I'm understanding you correctly, when you breath hold, your body's still subtracting oxygen out, and then you breathe, and the device perceives a bigger delta there, but it's just sort of making up for lost time, right? It's that delta is not real.
Delta. No.
Yeah, it's not a real increase in the rate of oxygen utilization, right?
Yeah. You do not augment your system at all. People think then, I have now augmented I was able to tweak my VO2. Now you're able to have an anomaly of your sensor-based data. That's
and it's interesting to know. Even I see this with DEXAs, for instance, as well, right? Very the hydration of the muscle is a big factor, right? It tells water as muscle. So you drink a gallon of water, it'll say, "Oh, you gained all this muscle." Well, no, you just gained water, right? And so almost any measurement can be hacked in a way that is not representative of physiology. It's a representation of, okay, now you just screwed with the sensor. Even in a negative way, the caliber mask is intended for airflow in the direction straight ahead, right? If I start blowing air out this way, I'm going to screw up the measure. I'm not changing my physiology by breathing that way, but I'm just screwing up the sensor, right?
Exactly. And that's kind of interesting, where you can kind of define how you use a sensor at all. I think everyone has a pro and con on those sensors.
Sure.
Of course, you have to check if there's any validation studies done on those sensors itself. We can go through later on a little bit about the technologies currently what we have.
Sure.
Kind of going all the way back to what you're saying also about Splendo. Splendo Health is a new called the CRF platform, right? And one of the It's also a Duke startup company, which we started, I think, almost 5 years ago or so. And one of my main reasons in starting this is kind of going through that whole physiology debate is that I think for 3 decades, the way that we do exercise testing in the lab has not changed at all. It's same, the old school approach. We have our bike, we have our treadmill, we have our very expensive metabolic cards, we have our ACG leads, and then we do some stuff. And if you're very enough, we maybe do some lactates, or even more. You can do maybe some arterial measurements there with an arterial line.
Or apparently, if you're at Duke, you have a catheter in the heart at the time you
Exactly.
do. I've never heard of that. Amazing.
I would say that the holy grail is still invasive CPX, which my colleague Merat Fudim does very well, and I think one of
that's incredible.
The big advocates for doing a exercise right head cath, and kind of making the case. We have done a lot of publications on that. But one of the stuff that we saw, and I think that's the most kind of interesting way of looking at CPAT data, is that if you want to do a right head cath and measuring pressures in the heart or in the lung, is if you're doing it in a resting state of a patient, that doesn't give you anything. Resting states of assessing some sort of a impairment of heart function or higher pressures needs to be dealt with or proposed with a high metabolic stress. You need to really kind of stress the system, kind of impact or the system itself to see how the body or how the hemodynamics and eventually also the whole oxygenation issue, how they kind of combine and couple well. And that's what we saw. So what we do is we're doing it in a resting first, of course, but then if we do it in a supine way, and that's our latest articles that we saw that supine versus upright. If you do it supine, you are not using the true kind of physiology based on gravity. You're making it easier for people to do that. So we overestimated people highly. So when you do a upright bike, which of course from a safety and hazard issue can potentially be a little hard because they need to come off the table. They still have the swan in place. They still have the A-line in place. And then you somehow need to, in a sterile environment, still have the transducers there. You can imagine another stuff there. And then put the mask on and then put all the protocol in, which we can do well because it's a very kind of defined SOP that we are working with right now. But then we see a fair amount of people who were potentially first not diagnosed with, but now if you do that true exercise test with a well-defined REM protocol, you can see those specific changes in the heart very, very significantly. So it's kind of how
you're saying I'm not going to be able to do that in my office anytime soon.
No, of course not. Good point. One of the things that I was looking for, from my perspective as Plano, is can we? I think still the almighty holy grail CPAT would eventually still be the invasive CPAT in the cath. But is there a way for us, first of all, to evaluate that same patient afterwards without having that very invasive assessment done? Yeah. And also, like a clinic of yours, can we have non-invasive way in still having some sort of a proxy of not only the mask of the VO2 and VO2 kinetics, but also potentially having a proxy of oxygen AV-diff? Do we have a better understanding about hemodynamics non-invasively? And not that we have the true number, the absolute numbers, we have a cardiac output of X and this and that, but can we see some slopes? Can we see some specifics that kind of defines the potential limitations of the system itself? And that's kind of where we started off with. So again, the old school approach is still the lab with all the fuss there. It's in 60, 90 minutes kind of a workup. You have a lot of stuff to do so it's a lot of calibration work and cleaning up and all that stuff. People need to go there to a lab itself, so that's also hard to do. You have a lot of logistics there involved. So I came up with I call it kind of CPAT 2.0. I was thinking, can we do this in a point of care way? And point of care means for me, as a clinician, is that if you are on the bedside of a patient, and let's do this. You do a cardiac echo. You put your echo probe on the chest. You do your 4-chamber, whatever. You're doing your measurements there. You're calculating your ejection fraction. You have that number in place in 8 minutes or so, and then you make your clinical decision at that time. Not a full wedge way, do a referral, and maybe in 1 week I know that number. That's with CPAT still the case, right? You need to do a referral, and then you get it. So I was thinking, can I do this specific modality of exercise, not in the lab, but in a way of any place, anytime, anywhere, on the bedside, with the true outcome of all the metrics I normally would have, and also have an instant reporting directly afterwards, where we can use that data instantly for any decision making. And then again, my way of that, the V2 number itself is only part of the whole story.
Right.
Independent if you are a patient or an athlete or a special force operator in a unit or so, it's just one kind of snapshot in how your physiology works, how your heart, lungs, and muscle are coupled in that specific time.
Yep.
Then you need to have better understanding, and that's the reason why I kind of got more in the nitty-gritty of how long and heart. And we have to have a talk about muscle, how those specific, how the specific limitations work, and if you can kind of derive those from your reports, then you can have, and I think that's the most important thing, a kind of a personalized, tailored approach in what is needed for this specific patient, client, athlete to be the best of himself. What is the best?
I mean, that kind of goes right back to where one of the things we said early on is that, we said, okay, problem can be delivery to the muscle, problem can be delivery to the lung, problem can be extraction at the muscle, problem can be at extraction or exchange at the lung. And once you define the limitation, then you can prescribe a recommendation that's very targeted to do these things, build up this system, and then you'll be able to improve your physiology in particular ways. But you need that rich data set, that analysis. So we spend a lot of time on the lung. I think that makes sense because that's what the VO2 sensor is measuring. But maybe let's move on to the muscle. So
good point.
Returns to the heart pushes it forward. The muscles, they're working or not working. And
what's intriguing. You can kind of, I call it, you can really even define inside the organ of the muscle itself also a VO2. Because VO2, if you're looking at the Fick equation itself, is delivery, hence flow to the muscle, how much blood flows to the muscle itself, versus your AV diff. So how much does the muscle extract from that flow? So you have I call it your macro VO2 on the side of the mouth, when you're measuring it L, no clue. And potentially, how can you measure that from a perspective of the muscle itself? Because if you know both of them, then you can have a potential way of, if there is a delivery issue, or is there a utilization issue, right? And if you have comparative data, looking at your VCO2 and V2 kinetics compared with specific kinetics you can measure from the muscle level, then you have almost the whole picture. And again, then the first question is how do you specifically assess that specific muscle, right? So I think a lot of people who are already working with CPET and stuff and are aware of near-infrared spectroscopy sensors, NIRS sensors, kind of very nitty-gritty, or sorry, very, very, very short, going through the technology itself. It's kind of a way, if you're looking at your SpO2 of where you have that specific finger clip on your finger, right? That measures your arterial. So it measures your arterial saturation. And what it does, it shines a little bit of light through the tissue itself in a very superficial tissue, not that deep superficial tissue. So the small arterioles that have that specific pressure wave or that pressure curve, a pulse curve there, and it measures the amount of oxy and deoxyhemoglobin. There's a lot of thoughts how you will measure that, but you can measure oxy and deoxy, and if you measure those two, the ratio between those two is your saturation. So how much is bounded to hemoglobin oxy, how much oxygen is bounded to hemoglobin versus non-bounded to hemoglobin, and combined you have your total hemoglobin. So NIRS does kind of the same, but goes deeper, goes around 1.5 centimeters into the tissue, goes into the upper layer of the muscle, can go that deep, but still the upper layer of the muscle, and kind of measuring your oxy deoxyhemoglobin inside that muscle itself. And you can imagine if you would have, is not the best way measuring flow. I think it's still kind of a good proxy of flow when you're looking at your, we call it HB diff. There's your difference between your oxygenated versus deoxygenated. But if you're looking at the tissue saturation, so how much does the system extract when there is flow coming in, that we can measure very well. And Again, it's not
So
about that we have a true number there,
are
but
there
yeah.
two sensors? Is it measuring a pre and post, or how is it measuring extraction?
Good point. So I have one of my sensors over here. So the sensor itself has a light and a
Hmm.
sensor, and that light is shining light to the tissue, and that light will scatter. That means that the light will scatter and go all the way back, and the scattering is being kind of collected in this specific sensor.
Okay.
And that scattering is based on the breaking of light based on a specific sensor and bandwidth of the specific sensor. So it's really a little bit depends about how the frequency of the sampling is. This is a 10 hertz, so we have 10 milli. So we have a very very fast way of measuring the oxy and deoxyhemoglobin kinetics of the muscle itself, and to see how they respond to that specific exercise.
Okay.
And it's all relative, right? Because we're measuring literally kind of, it's only volumes. We're measuring, so it's not volume measurements, but we're measuring concentrations. And concentrations are kind of always relative. You cannot say that, yeah, I think you can ballpark a little bit of what the normal saturation of a muscle will be. On average, it will be around somewhere between, I would say, 60 and 80% or so. But it's more interesting if you're looking at the slope of difference. So if you do an exercise, how does that saturation slope go down? And how far does it go up? And that specific slope back downward, my desaturation slope versus my resaturation slope, that's kind of an intriguing kind of phenotype of how the mitochondrial respiration of the muscle is doing, or how fast it's recovering doing the test itself.
So I'm actually much less. I had heard of NIRS before we talked, but actually I'm much less familiar with the technology. Of course, you use oxygen set,
Yeah.
O2 sat all the time, but the NIRS and infrared, of course, penetrates deeper. Just quick question: do you run into any issues with obesity in terms of getting deep enough?
Good point. Yeah, absolutely. So because again,
Okay.
you have the 1.5 centimeters or so of penetration you have through the skin.
Okay.
So if you have a subcutaneous fat layer, which is already that specific thickness, then you're measuring the capillary density and capillary flow of the subcutaneous fat, and not the muscle itself.
Right.
So there are ways of kind of doing it differently. First of all, I do a lot of stuff ultrasound guided, so you can measure with ultrasound. You can see exactly
how deep
is the subcutaneous fat layer, and see what's the location with the least amount of fat layer in the.
So you just pick your spot based on the ultrasound.
Yeah.
Look. Okay.
Upper thigh is always tough when you have obese people, because that's mainly also where the subcutaneous fat is located. There are two other locations I use. You can use the calf.
Okay.
And that's also a reason why you have definitely a lesser subcutaneous fat layer. And right now, and that's what we're doing here with Duke, is using a complete different kind of muscle, and that's the temporalis muscle. And
okay.
The thing is, interesting enough, because it's not a muscle that you normally would use during exercise, but our kind of hypothesis here is, first of all, and that's the good thing, there is no subcutaneous fat at all, even if you are obese. So you always have an easy, good signal there. But also that we saw is that combining, and it's kind of anecdotal here, but combining our oxygen AV-diff measurements in the cath lab with the measurements on the temporalis, they showed good correlation. So your desaturation slope versus your extraction in the invasive way that we normally would measure the direct FIC kind of comes together. And it makes sense in a way, because there's a lot of vascularization here from a brain perspective, and also from an evolution perspective, the brain is the biggest organ ever. So every system can shut down if the brain can maintain perfusion, right?
Right.
So that's always been there. There will always be perfusion, always be flow. So looking at potentially, so one of the ways that we're doing it is kind of a good example over here, because if you're looking at the muscle, the where NIRS was kind of originated from is called functional NIRS. You can also use it for the brain, because it goes through the skull, and you can measure deoxyhemoglobin from your prefrontal cortex perspective. So executive function measurements from a perspective of perfusion, you can always measure there. So one of the setups that we have also in our platform is combining two sensors. So I have two, these are train red sensors over here. and combine those in a setup where I am using this kind of combining one. So I have one here specifically measuring my prefrontal cortex, and one here I'm measuring my temporalis. So we can have a combined measurement of prefrontal cortex measurements. And we go a little bit later on why we should use this at all in an exercise. And I think it's intriguing what kind of data you can get from a prefrontal cortex measurements. But this is kind of our oxygen diff versus your prefrontal cortex kinetics on the same way of doing that. Yeah. And then of course you can still have another one on your
leg,
on your leg, whatever. Yeah.
One other question. So on the leg, I mean, depending on how much subcutaneous fat there is, let's say I do an ultrasound and there's 1.6 centimeters of fat. If I just strap that down a little bit tighter, if I just push into it, kind of compress it, is that enough to kind of get the job done?
Yeah.
Okay. But if there's 4 centimeters, then it's not going to.
No. You can also check with the probe. Just put some pressure on the probe and see. There will be some changes right now, for sure.
Yep. Okay.
So there's not, but you also will, of course, kind of compresses the muscle itself, because that where the muscle, again, you already alluded to with the DEXA, there's where the water lies. Subcutaneous fat is a little bit less compressible, but you can still see how that's being done. Yeah, absolutely.
Okay, then, very cool. So we have this sensor maybe on the thigh, maybe on the temporalis. We're measuring basically the reduction in concentration of oxygen within the tissue itself, right? Over time, is that correct?
The ratio between oxygen bounded hemoglobin versus non-bounded oxygen. Yeah.
And sampled, you said 10 hertz, so 10 times a second. Yeah. We're going to check the muscle and see what's the ratio between bounded and unbounded. And is it myoglobin that it's checking, or?
Yeah, that's always our stuff. I think for my it will be myoglobin, but I think it's kind of a mixed thing. But myoglobin will be the main globin that you were assessing. Yeah.
Okay. Yeah. All right. And so we're telling that over time, and then as the muscle starts working, it starts using that oxygen. Then we'll see that ratio start to shift. And then if we go back to resting, the muscle is kind of recovering after an exertion. Then we're going to see that recovery, and there's particular shifts there. Is that my understanding that correctly?
Yeah. Okay. Yeah. And what we see, there's a lot of validation stuff done against muscle biopsies and MRI, MRS, is that we saw the resaturation slope, so the recovery slope itself, as a kind of a definition. So if the muscle is in a recovery mode, the first thing that needs to be recovered or refueled is your creatine phosphate pool. Yep. So your creatine phosphate pool, and that's a very oxygen ATP dependent resynthesization kind of a process. So the faster you can recover, that means that you have a very well call it functional, effective way of refueling, recreating your creatine pool again in a recovery moment. So, and if you compare it, for instance, with heart failure patients, when you normally would see people go down desaturation, and then they go up, then you go all the way up, and you have kind of an hyponemic reflex. That means that you go up a little bit higher than you were before, because there's a lot of volume of flow, because it's dilated. You have much more there than you had before. But then also that the slope backwards is very rapidly in an athlete, and that the slope backward, normally in a heart failure patient, will go very slowly and then go up. So it takes maybe a minute or so longer to all the way go back in the system again. And that kind of defines your mitochondrial dysfunction in that regard. Yeah.
Oh, that's fascinating. Okay, so two questions come up. So, actually, first commentary. I myself, by the way, as I was learning this VO, so I started doing VO2s, I think in 2018, 2019, something like that. There was that 2016 paper from the AHA that VO2 Max is the most important determinant. Yeah. And of course, I was like, okay, well, then I need to learn how to do this. In med school, we're always taught the Krebs cycle and the electron transport chain and the mitochondrial function, this and that. And in my entire career in medicine, I had never heard of it again. Right? That was that I learned it in med school and then just never revisited that ever again. And so it was fascinating to kind of come back to that mitochondrial metabolic understanding. and then have to learn it actually in greater depth than I learned it in med school. We learned maybe the pieces, and particularly creatinine phosphate pool was never discussed in medicine. The notion that we have these, the free ATP and then ATP that's bound to creatinine, and so it's a rapid source of phosphate that can actually serve as a metabolic, a nearly instant metabolic access. And then we pull from that pool first, and then we keep trying to refill that pool, right? So all the glucose metabolism, all the beta oxidation from free fatty acids, all of that is kind of going into refilling that pool. And part of the value of creatine as a supplement is you're just slightly increasing the size of that pool, right?
Yeah, exactly. And kind of starting there about kind of the education of how energy systems work is not a start-stop, so you don't have, let's first use our ADP first that we have already there, and then we go to a creatine phosphate, then it's depleted. Then we go to a glycogen, that's depleted, and then we go to aerobic cycle. Now, every cycle starts from the beginning at the same speed. Right. Only the ATP flux based on the cycle itself is different. So, of course, your ATP that's currently available, that's the fastest. Creatine phosphate, that's your second fastest. So, that specific ATP flux is very fast. Your beta oxidation flux is very efficient, but very, very slow.
And that was the piece that I think was completely not taught in med school at all, is the speed of the reaction, which is actually, it turns out, the most important part. So, of course, they skipped over the most important bit. But, the notion that you have a very large pile of free fatty acids in your body as a whole, but the ability to flux that into ATP is slow, relatively speaking, right? And so if the demand rate exceeds the potential speed of that flux, you have to rely on another energy system, right? And so, if you're just walking, hopefully as a fairly healthy person, most of that is from fat because it's within the capacity of that speed of reaction. But the minute you start, running, sprinting, maybe not sprinting, but even jogging, you're going to exceed that. And that system's still on. It's not that it suddenly goes away, but you start having to burn glucose as well in order to make up the difference between your demand and the speed of the availability.
Yeah, and if you really want to make it very small, I think if you really would define how we as a kind of a species are defined and so unique, is our ability to have a hybrid system of utilization of substrates. We do not completely align on one single substrate. So, for instance, let's go over the substrates, right? What we can use. We have, of course, our carbohydrates. We have our glucose, carbohydrates. Glucose in the form of glycogen in the muscle versus glycogen in the liver, and you're circulating glucose. Then we, of course, have our free fatty acids, right? In free fatty acids in the blood circulating. Also, those are stored in the subcutaneous fat, but also intramyocellular depots or lipids droplets, where maybe we have a different discussion about how that's being defined as, and how beta oxidation and fat oxidation is such an important predictor of being at risk. Then you have another one. We have lactate. Lactate is not a byproduct that is a waste product, whatever. It's apart from the acidotic potential piece that is different. So you have a lactate acidosis or a lacturemia. That means you have a high lactate level in your blood. If that's the case, lactate is for instance, the heart can utilize lactate very easily. The muscle can utilize lactate very rapidly. If you want to define an athlete is he has low lactate levels, not because he's doing so well. No, he is clearing it so well. Right. It's all about clearing. It's all about utilization. If you have a patient who has a higher lactate level, is not based potentially that pH is low, which you still need to assess with ABG, of course, but you can have a higher lactate and normal pH based on your inability to utilize lactate itself as a substrate. So now our last substrate are with 2F1. We have, of course, our protein with muscle wasting and stuff that we can have. And I think one of the other very interesting substrates is ketones. So we have a huge amount of palette of utilization of substrate that we can kind of use. And if you would say to me, how do you define a very high risk patient and how do you define a most elite athlete? Is not based on the VO2 max, it's based on how easy, how adaptive are they to really utilize every different substrate, being adaptive in any given situation to utilize this. If you are a heart failure patient, you think, oh, heart failure, that's from a cardiology perspective, a single organ failure, hence the heart is doing stuff, cannot put, that's not the case at all. So the heart failure patient is a systemic disease which is profoundly being seen in patients who also have mitochondrial dysfunction. That means that their utilization of substrates is eventually impaired due to their long time of an impairment of delivery. So an acute heart failure is an MI, for instance. That's a different kind of story when you have 4, 5, 6, 10 years of a heart that does poorly based on a very rigid way of contracting. So a good example in how heart failure is being seen, we call it an LVAD. An LVAD is that you kind of a device that you can help the heart pumping more blood to the system. If you would think that a heart failure patient is a single organ dysfunction and that his ability to have a lower VO2 is mainly based that he has a impairment in delivery, if we then solve the delivery issue, you put a device in which can just, you have a dial, push more, problem solved, right?
Right.
Now, if you're measuring the VO2 on patients who have an LVAD, pre and post, VO2 does not change.
Oh, that's so amazing. That's fascinating. So even though you improved the effective cardiac output, right, with the device, nonetheless, you don't get a change in VO2 max because it has become, after so long, a mitochondrial dysfunction at the muscle level, even though maybe it started as a delivery problem on some level.
Yeah, exactly.
Fascinating. And maybe that's why also cardiac rehab works, right? That's part of the, it's not, maybe it's also inherently, maybe it's also improving cardiac function, but if it's improving mitochondrial function, then you may have better outcomes.
Absolutely. And then kind of going through if you would have a NIRS device there, we also did some publications on that, is that the most profound inability to do a DSAT. So a DSAT also tries a DSAT means utilization of oxygen. If you do not have a desaturation in the muscle, that means the muscle is unable to utilize oxygen, right? So delivery exceeds utilization. You can have a lot of flow going through the muscle, but if the muscle says, I have no clue what to do with that, then you have still the same issue.
Right.
So that's kind of how you would, and if you would want to be able to change that is, and that's also what we did at Duke as in the prehabilitation environment. So how do you optimize a patient with this specific profile, phenotype, going through surgery? One of the ways of doing that is really focusing what kind of interventions can I do that have a profound focus on muscle mitochondrial function. And then it's all about high intensity stuff, and mainly the sprint high intensity stuff, not the above 30 seconds and above. So not the 4x4s of the 1, 2, or 3 minutes, because they are much more triggering on the stroke volume cardiac piece. If you do a very, let's say everything between 15 seconds or 10, 50 seconds all the way up to 30 seconds of all-out sprints, those have a specific triggering on your desaturation of the muscle itself. And that's the reason why we saw in a time frame of 3 or 4 weeks, we can increase VO2 max in people with a very low VO2 easily with 1 or 2 or 3 meds. Yeah.
So that's fascinating. I mean, and let's come back to this after we've kind of, but just as a hint right now, right? This notion that, okay, people are out there doing 4x4, Norwegian training, whatever, or then, they're doing zone 2 or whatever. Well, if the issue you have as your physiology is your utilization, your mitochondrial dysfunction, then you're training your heart, you're training the wrong thing because your heart's already supplying more than the muscle can use.
Delivery is no issue. Yeah, absolutely.
And so you're improving delivery in a system that already has an excess of delivery.
Yep.
Right.
Exactly.
And maybe training. So now you're saying this sprint training, the high intensity work, increases the muscle's ability to utilize whatever is supplied.
Exactly.
Once that catches up, then maybe you can have further benefit at a later time from doing an improvement in delivery and then improving,
Yeah.
But you have to diagnose first, right? So figuring that out.
Yeah, that's the reason why we have that compared kind of sensor stack that we currently use to really deep dive specifically in, okay, now we have this VO2, and let's for instance use the Mensaker paper, right? Which they found out with specifically in the high and the so you're on the low, you're below average, above average, high and elite. So for instance, if you have a patient or a client who is in the low percentile of his peer, meaning in his age and gender, he is on the lowest tier, so below 25% of his group. That's low, right? So then the question becomes, okay, we know you're low,
Why?
but exactly why. Now we need to do something. There's nothing there. It's not a fate, right? It is something that you can still. It's still, regardless of age, even if you're 88, 99, 95, it's a modifiable factor. It's always modifiable.
This is, by the way, this is something that I harp on a lot in my own other podcasts and other videos. Is the reason VO2 max and this kind of physiology, and there are other factors beyond VO2 max, which we'll get into right very shortly here. But the reason that I find it so important is that unlike a bunch of other things we can measure, it seems, at least early data, when you improve VO2 max, as long as you're not manipulating the sensor, as long as you're not abusing it, right? But if you improve the physiology, you improve the outcomes, right? Whereas, homocysteine is my favorite example. It can give you vitamin B. Your homocysteine will go down. Your risk doesn't change at all.
Nope.
I've just manipulated the number, right?
Exactly.
So, whereas VO2 max, if you actually do the physiologic changes, then it actually does seem to improve the actual mortality, function, delirium, all the things, right?
And again, if you're maybe you have to create a Mensaker paper link, whatever, in this podcast. But if you're looking at the specific paper there,
that's the paper Atia references most often, right?
Exactly. Also looking at the hazard ratios when you're changing from a low to above or changing from a low to below average, is that. And that's kind of a good and a bad thing. The good thing about being low is that of course, is bad from a risk perspective. It's a good thing about your potential optimization is very easy. That's the reason why we are able to do this in a 3 or 4 or 5 weeks period. Yep. I cannot get you to the low to the high, but I can get you from the low to below average. And there's still a 95% decrease in your overall mortality or the risk of cardiovascular events in a time frame of 4 or 5 weeks. And
so I mean, that again, I harp on this. I appreciate you kind of pointing that out. It's always on a diminishing returns curve, right? The movement from the lowest to even a moderate VO2 max, the mortality benefit is going to be huge. It's a significant improvement. Going from moderate to high, there's some, right? Going from elite to beyond elite. If you go from 99th percentile to 99.999%, there's none.
Somewhere between 2 or 3% or so. So that's not that much.
Yeah.
But no, absolutely.
And the time it takes, the amount of time, energy, effort it takes to move from the 99th percentile to the 99.9th percentile is huge. I mean, that it takes years to move that little bit. Whereas moving from the 5th to the 50th, maybe, you're saying it can be done in a matter of weeks?
Yeah, for sure. Yeah, again, and also that's the reason why we need to have this specific assessment done. Is not just, you have a low VO2, let's run more, let's bike more, let's do the stuff, right? Because
it's what
you think I do a very specific assessment and then everything will work, right? Whatever what I do, I just need to do it more. No, you don't need to do it more. You need to do it specifically on what we're seeing on your limitations based on your potentially your ventilation dysfunction, so breathing dysfunction, potentially your cardiac delivery issue, or your more peripheral muscle mitochondrial dysfunction, or a combination of everything.
So I think that's a good place to kind of move into this notion of, okay, the VO2 max everybody talks about as a number, but in fact the process by which we measure approach to VO2 max, whether that's during all out or whether that's during a metabolic profile that's more traditional ramp style test.
Yep.
It's a very rich data set, right? It actually, we were talking about the different substrates, right? So fat, glucose, glycogen, lactate, and creatine, phosphate in the end. We actually get data on all of those metabolic systems in not just the VO2 max as a number, but the data set that we collect, right?
Yeah. Now, one of the things that kind of going back to a discussion we have about fat oxidation. So, if I go back to the first, second, and the third wave of COVID, so I was one of I was the only scientist at Duke that was able to do research in that specific time. Everyone else was gone, and need to be clinically needed to be at Duke. So I had a interesting also conversation with the RB that it was my own kind of risk that I would take to go into the room. So that was the first thing that we did. We did a full metabolic cards and stuff, a lot of assessments in the first, second, and third wave, before the steroid use was there. So I have a profound exposure in the ICU where we had no clue at all what was going around. But kind of making a long story short is that what we saw, and that's kind of still also the case we saw in septic patients, RDS patients, and also in the preoperative assessment patients, if apart from VO2, your ability to be metabolic flexible defines risk. So if you are in a high inflamed state and you cannot change to all the stuff that we saw based on your substrate, can you go back from carbohydrates to fats and from fats to carbohydrates again, or potentially use ketones because you potentially can be ketogenic even in the ICU? Or do you have a higher lactate and your lactate clearance, you can still use this? All those systems are off, and you're only relying on one system, and one system alone will always be there. That's your carbohydrate system, your glucose system. And the reason why it's there, because of the brain. The brain is mainly dependent on glucose. Second, you can use is ketones, but also there's a lot of stuff there in the ketogenic, in the ketosis, what you potentially can be. You can still also be very beneficial for the brain. Another discussion potentially we can have later on in another podcast to show how ketones kind of rely on this specific physiology. But the people who were eventually able to survive were the ones who were able to change those specific substrates. If one was only constantly only relying on carbohydrates, those were the ones with poor outcomes.
Okay, so let's for our listeners here. So when we're measuring, VO2, and we can get into the details of this here in a moment, we get data on the ability, the capability of the body to utilize each of those different substrates. So to use fat, to use ketone, to use glucose, glycogen, lactate, and creatine. And you're saying that you were able to tell in COVID patients, in ICU patients, that if they had that metabolic flexibility, all of these systems were able to provide energy to ATP, then they were more likely to survive, versus if they were just down to the back. Glucose is always the backup. If they were just down to their glucose system, then that one metabolic system may not be enough to actually achieve what was needed. Yeah. That's fascinating. And is there any, so this is something I don't know, is there any correlation of that flexibility with maybe longevity outside of disease states? Do we have any data on that?
Yeah, good point. I think, I'm not sure if there's data, anything, but what I do see, and there's always kind of the discussion about, if you're looking at the VO2 metric itself, about responding versus non-responders, right? There'll always be people who respond very easily, very well. You do something and they increase the numbers. Sure. You think, there's no effort there, and they already... Yeah, the same guy,
hypertrophy, right? So somebody goes and curls twice, and then his bicep is 5 times bigger.
And already someone who has no running experience at all and runs a 5K in 20 minutes because he can do it, right?
Sure.
I always say that they chose their parents wisely because they have a good gene set, right? What we see there is that if there is a potential. The non-responders can still respond on utilization changes. So One of the assessments that we do is called the metabolic profiling. So based on your VO2 and VC2 kinetics, so VO2 is mainly utilization of oxygen from a consumption perspective. Your carbon CO2 is more or less your oxidation of substrate. So combining those two numbers, eventually they will create you an RER, respiratory equation ratio. And those specific ratios give insight in what substrate is being used right now. So for instance, when you're eating a mixed diet right now, for instance, and we're measuring your ratio, then the mixed ratio is 0.85. That means you have 50% of carbohydrates utilization and 50% of fats. If you all the way go downwards to 0.7, then it is mainly fats, and 0.68, for instance, is ketones, and all the way up, 0.85 and up to 1 is more profoundly glucose, carbohydrates, and if you are above 1, then it's only carbohydrates. There's no utilization of fats there. So if you would do, and we have a calculation, just an equation that was done and validated, I think maybe 20 years ago, that those VO2 numbers, VO2 and VC2 numbers, you can calculate your fat oxidation by calories a minute or grams a minute. And if you have a ramp test, so a rapid accumulation protocol on the bike, where you have I would choose a little bit larger block. So if you have a block of 1 minute and 30 seconds or so, and you're constantly increasing that resistance, and you create not a time series graph, but a oxidation graph versus heart rate, you can see how those specific fat ox is going up, have a max, kind of then plateaus a little bit, and then goes down again. And when it goes down, then carbohydrates go up, and they kind of cross at that 0.85 mark. And if you're looking at your heart rate zones between 0.85 and all the way here, that defines your highest utilization of fats in that given heart rate zone. And that's, for me, there's a lot of discussion about zone 2, right? That's, for me, I think, the most robust definition of zone 2 as a fabric of intensity, surely relying only on beta oxidation.
I think that's important. Yeah. I think that's important to emphasize, right? Because you see so many things. Okay, one of the things drives, I'm sure you get this a lot as well, is there's this idea 220 minus your age is your max heart rate. Well, it's not your max heart rate. That's sort of a population rough, rule of thumb, right? Yeah. Your max heart rate may be significantly different than whatever that number is. Similarly, your zone 2 is actually, in an ideal way, physiologically defined, meaning it's defined on the basis of your substrate burn up to a relative level of intensity of effort.
Yeah.
Right? Meaning we talked earlier about that, the flux of ATP from the fat oxidation system, right? That really is kind of your zone 2, is the maximum flux from the fat system up until the 50% mark, right? Yep. So when we start using glucose. When it gets to 50-50, that's kind of the end of your zone 2, right? Exactly. And that's not, now, whatever your heart rate happens to be is not necessarily a percentage of your maximum. It's certainly not a percentage of 220 minus your age, right? Exactly. Now we're really kind of getting far away from actually what this is, right? And so you need this, you need VO2 data in order to even define your physiologic zone 2, right?
Yeah, and again, I have done so many tests. If I compare it, for instance, with the Fitbit numbers or the Garmin numbers or the Apple numbers,
that's important to know. Yeah. So what have you seen? How accurate is that? The Garmin
mainly overestimate. So Apple and other stuff you have. So if I would follow the Apple, Garmin, and the Fitbits, I would be thinking I'm training in zone 2, but mainly training in zone 3, potentially a bit in zone 4.
Okay.
So I'm not doing.
How accurate is the VO2 max estimate that these devices give?
Those are pretty reliable because they're based on the equations that are validated. And if you have a metabolic card that's also being validated well, you're looking at percentages less than 5% on.
Very good. Okay. So at least for that one number, they're pretty decent.
Yeah, absolutely. Yeah.
Okay.
And also, what I would use not only as an assessment of which your zones are specifically heart rate zones for zone 2. And I've kind of, Peter G I think has a kind of an intriguing kind of way of looking at the pyramid, right? Where he says that the zone 2 is your base of the pyramid. Mm-hmm. If you're able to increase your width of the pyramid based on you have a much larger kind of base on utilization of fat. So for instance, I do my first assessment, and my zone is my heart rate is between 90 and 105. That's my zone 2 heart rate zone. And then I train stuff, and eventually I reassess myself, and then my zone becomes 93, 120. So wow, then my scope of ability to utilize fats being very efficient is much more profound. So my base on my pyramid for my zone 2, zone 3, zone 4, zone 5 has a much bigger base, which eventually can build the other zones much easier on. Yeah.
I think, we'll get back to that when we talk about training and improving these deficiencies as we identify it. But when we're trying to first identify the deficiency, I think we should also even define this idea of a ramp test. A simple idea, you're standing still at first, then you start walking very slowly. On a treadmill is what I've been using in the office. Yeah. I think you're going to convince me to switch to assault bike.
Absolutely. Eventually, yes, I will. Yeah.
But basically, you're doing a certain wattage of work, right, one way or another. And then you do a little more and a little more every minute and a half. You kind of do a greater intensity, either faster on the treadmill or the bike, or harder or whatever. And you keep going more and more. And so the rate of energy demand from the muscle keeps going up and up, as I need more energy per second on an increasing basis, right? So. Yes. I'll throw it to you, even better than me, but so what do we usually see is that on a healthy person, as we start on a slow treadmill, and we see what the RER is starts out around 0.8, so, I think a lot of the time.
Cool. So if you look at the RER numbers, for instance, let's start with that. So again, we were saying that there's a kind of a derivative of subutilization. When you start, it can be even a little bit depends on also anxiety. So if you have an anxiety, and that anxiety is mainly, and everyone has a kind of a test anxiety, because I'm now on my bike and I need to do something, and there's always people always think when they're doing an exercise test, it's a pass or fail test. I need to do this and I need to pass this somehow. So there's a lot of potential pressure there, and I can tell you, it's always interesting when I do a lot of debrief with patients or athletes and also operators, based on the numbers that we saw. They aren't that interested in, for instance, if I say your cholesterol was high. Okay, that's all fine. But I say your VO2 was lower than expected. That's the worst metric they can have.
Sure.
There's always a kind of competition. Sure. But that's my friend had. What does it mean to say? They never compare cholesterol levels.
Right.
No.
Right.
So it's a very kind of a highly kind of passionate metric somehow, if you talk about it, right? So going back to the RER. So what happened eventually, that's the reason why a normal setup of any exercise protocol we use, we have always a 1 minute of baseline. Baseline means just sitting on the bike, doing nothing. And the main interesting there is I want to have a kind of a calibration moment of the NIRS sensors and stuff, that we have a full kind of a zeroing on all the sensors. Then we have I call it kind of a priming or a unloaded phase. We mainly choose 2 minutes. On the bike means just doing your bike without any resistance. On a treadmill will be a little bit, but maybe just a small walk and
super slow,
Yeah. And on the air bike means a RPM of around 30 or maybe even lower, 20. It's very, 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 very slowly. And what happens then, if you compare the RER, it can be a little bit higher in baseline. And when the exercise starts, it's kind of interesting how the veto of the system works, because your mind goes away and physiology takes over. Because the reason why, you cannot say to your system, okay, I'm going to exercise, but I maintain let's lower my heart rate. You cannot do that.
Right.
It's your autonomic nervous system that takes over, and you kind of passenger on that, right? So you just have to follow how the system, and you have a demand, and the system needs to respond on that. So what happens then? You have a kind of increase in your RER, and when you then start off the exercise, the RER will decrease. And what you will see is potentially can go down all the way. A little bit depends how good you are conditioned. It can only go up even down to 0.7 or so. So what it really does, it always goes down to the utilization of the level of fats mainly, and then you start over again, and then you have that specific increase. So If you then go up,
so as it goes down, you're increasing the demand to some degree on ATP, right? Increasing cardiac output, increasing all this, to supply your muscles with oxygen so that they can burn. And they primarily respond initially by burning fat, and so that RAR comes down to 0.7, which is the fat burning sort of ratio between oxygen use and carbon dioxide production.
Yeah,
right.
Exactly. Yeah.
And if they burn ketones, they can even go a little lower, like a 0.68, I think you said.
Like
you kind of see that sometimes.
Yeah.
Okay.
Yeah. And then, of course, when the intensity is gonna increase, then you will eventually also have an increase in your RER, and a little bit depends.
And that's the glucose system starting to kick in. Is that right?
Exactly. So then, it goes. Kind of the first piece will be, of course, a optimization of your bad oxidation, your fat oxidation. Sure. When is that kind of maxed out, and you still have a higher demand, you're still asking more. Mm-hmm. Then you have that increase in carbohydrate oxidation. That will be decreasing. So then you will see those numbers of 0.85 and up. And if you're then reaching one of the kind of, let's call it, biomarkers of how do you define if a test was done maximally, yes or no, is that RER needs to be 1.15, 1.1 or so, to make sure that you were in that space of only utilization of carbohydrates and glucose. So there is no way, and that kind of defines also being maxed out, right? To kind of create that. So, and that RER number you can also use. So if you do a ramp submaximally, means you can stop with RER as 1. Because if RER is 1, you already know if I go further, there's no interest from a metabolic perspective. I'm only using carbohydrates. But when I stop at 1, it was mainly around 80% of VO2 or so. It's still fine. There's no issue there. There's no hard burden in doing that. But then you still have that very well nice curve on fat oxidation versus carbohydrate oxidation. If you really want to push it and start moving on and increase that specific resistance in the bike or speed on the treadmill, then you will go all the way up to above your anaerobic threshold and eventually also to your RCP point, respiratory compensation point, where you have that higher CO2 levels and need to breathe out on that. There's a lot of discussion here in what does anaerobic thresholds or ventilatory thresholds mean and say. We only use them specifically on the athletes who are interested in more the endurance piece, because your anaerobic threshold itself is only needed if you want to do some specific training in a specific zone, right? If you define limitations as muscle, cardiac, or potentially ventilation, then the only zone 2 training is of interest. And you can even argue, is the end of zone 2 near my anaerobic threshold already? So when I'm going from zone 2 to zone 3, I'm already in that space specifically already there, because I'm going upwards to my kind of changing from my fully aerobic work to a more anaerobic work right there. But again, there is a lot of, and even if it's worthwhile doing that, a little bit depends also on your time frame. So if you go back to what I use in my athletes, and that's mainly in the basketball and soccer, and for instance also rowers, is if you use the 1 minute allowed, that is, first of all, we use, for instance, 3 systems. Right? So we have the caliber, we have our NIRS systems and the polars, and we have 3 systems on the roll, and we have 3 air bikes. I can do a team of 28 in 2.5 hours, which is with instant reporting there. That's if I go back to my early days, and with soccer teams, for instance, when you only have 15 athletes, it took me 3 days, where I only can do 5 a day in the kind of old school lab environment stuff. And now I have, even for the head coach or the strength and conditioner coach, I have instant reporting there. And what we kind of using it as a metric of, there's a lot of discussion there, but how do you define, if you're looking at the athletes from a college perspective, how do you define from a VO2 Max perspective that you are a D1 athlete or D2 or D3? And again, I'm the most unbiased person from a functional what a basketball player can do, or a soccer player can do, or a role player needs to do. I'm only interested from the perspective of physiology. So I argue, does a VO2 max of 70 makes you the best basketball player ever? No, it will not. No. What it will do, it gives you the fundamental piece of doing, for instance, on a tournaments, back-to-back games and maintaining recovery. And secondly, also being able to be very efficient in your way how you maintain the specific performance readiness, right? And the same everyone else. It's kind of always on top. And I must say, it's always intriguing to see the big differences in athletes. It's not always the same. Yeah.
What kind of differences have you seen, like even on a soccer team or something
like that? No, can be pretty used. For instance, you can have all the way down to the 40s from girls who are in the 18s, 20 or so, all the way up to 65 in the same group. So that's a huge difference there. And also, again, making that case is that looking at myself, again, it's anecdotal, but people think that doing a VO2 max test or a CPAT test as an annual assessment itself is I've done it and I know my VO2. I can tell you, and I've done multiple, I do almost any training I do is using metabolic car data. So I have a huge amount of data, and also for my athletes and all that stuff, is you can decrease your VO2 in a time frame of 2 weeks with maybe 3 or 4 meds. That means I can go from above average from the Mensaker paper to low in 2 days. And one of the things that I saw when I had the flu, when I had COVID. So you can have a huge hit, and you don't think that changes. So because it's such a coupled metric, it's not a single organ way of measuring stuff, it has a huge consequence on your, let's say, inflammation state itself, and how fast you can change. So, and of course, when you have the old school cards with the big masks and all,
pipes and the tubes,
that will be almost impossible to do. And now with when we have our small devices like the caliber, we are able to measure this. And I will always argue, and again, of course it is inexpensive, but also expensive still, right? But if you're able to afford such a metabolic card, which currently right now is $500 or so, what we use, if you also use it and as a kind of going back to that specific metabolic profile or that zone 2 training, I use it for my zone 2 training. I know based on my metabolic profile, which heart rate zone I have, but I also know that heart rate in itself can be confounding based on my sleep hygiene, my stress, overreaching, all that other stuff. So if I do my zone 2 and I have my mask on, I can make sure that my RER is in that region, regardless of my heart rate, heart rate. So I can really see that I'm only using my fat oxidation and not using my carbs. And sometimes it can change very, very significantly. Yeah.
So let's talk about that a little bit. So we talked about the ramp test. We're going faster and faster and faster. So the intensity of demand keeps going up. Initially, there's a drop from maybe your resting state where you're burning some mix based on your diet or whatever. Burning more fat, so it drops towards 0.7, maybe you get, or even a little lower, maybe sometimes. Then starts going back up because you start needing to use glucose. You use more and more glucose. You cross that 50% mark where it's a 50-50 mix at 0.85 RER, right? And you progress on, your fat goes down, your glucose percentage burn goes up, and you reach eventually RER1, which is 100% glucose. And going past that, you don't get any more sort of metabolic data, but you get your VO2 max sort of peak information there.
Yeah, you eventually
do on a separate test.
No, what you eventually will get, so if you're looking at the VO2 graph itself, the VO2 will go up. And then, of course, you have that specific plateau point potentially.
Right.
And your CO2, your carbons, because your still utilization of carbs is still there. So the CO2 will increase. And that specific kind of slow point where the one goes up and the one kind of goes down, that's one of the stuff that we're looking at right now, if you're able to doing that.
I see.
And that's kind of also where we have that specific plateau there. Okay. Fortunate enough, comparing the ramp protocol to the 1 minute allowed, is that the 1 minute allowed is a micro version of the REM protocol. People think
Oh,
you cannot reach VO2 max in the 1 minute allowed, because we need to have that time to get all those, what you're saying right now. You start there, and then you move that, and then you do that, and you do this. That's true, but what happens, it all depends on recruitment. So that's the reason why it does not work on a normal bike or a treadmill or running or sprinting and such. If you're using it on an air bike, where you have such a profound recruitment of your
the
upper
arms
extremities,
and
your trunk
yeah,
and your legs. So there's a
everything.
huge recruitment of muscle, huge. And if you do it in a 1 minute allowed kind of fashion, is that in the first 30 seconds or so, I always say you kind of die twice doing the test.
Okay.
You die once when you're kind of seeing the 30 seconds and you think, 1 minute is still a little bit longer than I was thinking. And then you die when the 1 minute is over.
Okay.
And
right.
I would say, from a data collection perspective, the magic is there in the last 20 seconds. Then where it is all back out. Because what we're doing is right now is what we talked before on all the energy systems. All the energies, because the demand is so high, every system is in upper flux. They're not the same speed, because they're upper flux. And at 30 seconds, all the other systems kind of shut down, because you have a high lactate, your glycogen stores are almost empty, creatine phosphate is gone, you have your ATP is already done. So the only way for you to rely to making sure you get that 30 seconds done is your aerobic system right now. So what you're kind of doing is you're kind of making sure every single system is done, and you're only relying on that last system. And then you see that VO2 max again, even in 30 seconds, going all the way up and maintaining there. And that's kind of going back to the Ava Hill model.
Yeah.
I think it was never ever happening. You need to have that more profound, longer system when you have that kind of increasing of those VO2 kinetics. But you can do the same thing in the 1 minute. Only the downside of the 1 minute is, going back to the thresholds, because it's so short, we really cannot, as of yet, we need to see if there's some data that can even help us out, dissect any thresholds, because the thresholds are only there when you have a more...
Thresholds meaning zone 2 and lactate threshold and that kind of stuff. Just it happened too quick. It's hard to see any of that.
I would kind of use it as, and I think all depends on what your needs and what your questions are, in a environment like basketball, environment like soccer, maybe football, and also in a special operating operation force unit. They are not interested in any unit, in any thresholds. And basketball player is interested in his aerobic threshold, because he is sprinting back and forth. What his needs is, first of all, my base VO2 max should be high. Okay, one question: is it high enough? And how do I make sure it stays that way? Or if it's a little bit lower, I need to optimize it. How do we optimize it? And then that all you can do with a 1 minute allowed test itself.
So I want to get into there's several directions. Now I want to kind of get into the implementation aspects of this. So you mentioned VO2 as a marker. Maybe I'm putting words in your mouth. You tell me if I'm wrong. Of kind of recovery capacity. That's an interesting kind of metric. I think you talked about the notion of lactate threshold only for athletes who want to do endurance work, where that threshold becomes important. It's not necessarily a health metric, right? If we're imitating endurance athletes training, even though that's not, I have a longevity goal, I don't have an endurance performance goal, then I'm optimizing something that doesn't really matter, right? But optimizing VO2 max does matter for not only longevity, but also recovery capacity. That's an interesting, I wasn't familiar with that actually. And then I think the other question I would say is, well, actually, let me take one more tangent before I get into optimization process. But the other tangent, you mentioned COVID and flu. I've seen a couple of papers indicating mitochondrial dysfunction as a function of long COVID or post-viral syndrome if it's not COVID. Flu can do the same thing.
Yeah. Now, I think the main limitations on long COVID patients that we also see here, we do currently a large trial on post-COVID, long COVID, also on after ICU stay, is that the main limitations is on the level of mitochondria.
Oh wow! So
it's not so much on the level of cardiac output. Is what we potentially see in our NIRS signaling. That is a very defined impairment, and also good because we also have an optimization intervention leg on the study, is you can change that very rapidly. Yeah.
So let's get right into that. That's a good place to jump in. For each of these kinds of deficiencies, the utilization at the muscle, metabolic deficiency in terms of maybe fat oxidation capacity or
Right.
lactic oxidation capacity, maybe go one by one. What are the
Sure.
interventions?
So my start will be zone 2 will always be of importance. So how would I kind of explain zone 2 is where every system works at their optimal but submaximal level without being a profound limiter. So the system works well on the muscle level, is just kind of cruising along. The delivery of heart, it is a little bit up, but it has no issues, is matching well. Your ventilation is on the lower side. Of course, your frequency is a little bit higher, your tidal volume a little bit higher, but all it matches. There's no specific limitation when you do this work. When you do sprints, when you do high intensity, when you do 4x4s, there's always, that's kind of what you're doing it for. You're always
bumping
looking
into
at
some limitation.
Yeah, you need to have some limitation. You need to see, I want to stress this system out, and I want to stress this system out. So I want to limit this system to really trigger, to really make sure I get that stuff. So zone 2 is always kind of my kind of go-to modality, because that's the thing where everything comes together.
If and zone 2 defined by the RER, right? Defined by the physiology, not the heart rate, right?
Yeah, the heart rate. Yeah. The heart rate versus, of course, your fat ox max. So what is your highest fat oxidation on that given heart rate zone that you're using it right now? That's what you would use, right? And again, if you're looking at a more peripheral muscle limitation, we use then I want to use it as a high intensity. I find 4x4. That's high intensity. So anything, let's say any intensity higher than 1 minute is high intensity, is HIIT. Any intensity high below 1 minute is sprint interval training. Okay. And sprint interval training and high intensity interval training, I found specifically different. Sprint is specifically aligned for, and again, I won't go any above 30 seconds, because then you have it's kind of the gray area when you're looking at where the heart comes into play versus the muscle comes into play. When you have a very focused intervention on the muscle, everything below 30 second sprints. If you want to have a profound focus on stroke volume augmentation, go above 2 minutes. And then, of course, you have the 4x4s. We have a discussion later on how we define specifically 4x4s, and if there is a 4x3 with a 3, whatever, you're going to change. But if there is a limitation of muscle, then it will be sprints. And what I would always do, sprints are pretty difficult. You can use, of course, the bike. The air bike I find most useful. And where I start off with, if someone has such a specific limitation, not instantly go to the 30 seconds, but I will go by 10 seconds. So we would choose a 10-second sprints. When we really start from 0 on the air bike, that means there is also an acceleration piece, because you need to get that thing going. So it means that there's a lot of recruitment from almost a resistance training there, because there's from 0 to resistance. Get that stuff done. Make sure you have the 10 seconds all in. When you're done, then you wait for 1 minute or so, and you do that 4 to 6 times. That will be one. And then you increase, for instance, every 2 weeks, going from 10 seconds to 20 seconds, and with 20 seconds to 30 seconds.
And how many times a week?
I will go max 2 times.
Max 2 times per week.
Yeah, and always combine that with your next session always be a zone 2.
Okay.
Be sure.
So how does this? You mentioned resistance training. I mean, how does that combine? How does that compare to? Let's say you're doing a squat. I mean, you're doing 10 reps. I mean, it can take you 30 seconds.
I think exactly that. I think even if you do sprints and you go everything in the 10-15 seconds range, is always kind of resistance training itself, because you're pushing a lot of wattage. And from a perspective for the air bike, there's a lot of wattage from your upper, your trunk, and your lower. And if you do a sprint on a on a bike, you have the same from the muscle. So it's kind of already a all-out kind of resistance training, right? You're looking at you want a RAM constantly right now.
Yeah. So if you were doing zone 2, and we can get into zone 2 here in a second, maybe a protocol or something like that. But if you're doing your zone 2 training, and then you're also doing some resistance training, let's say 3 times a week, you're doing heavy. I mean, in the whatever 5 to 12 range, right? Maybe
Yeah.
5 to 15, getting pretty close to failure in that. Are you getting some of the benefits of the mitochondrial effect on sprint work,
Um,
or is that a separate?
yeah, the thing is, the biggest difference between the two modalities are mainly, if you're looking at sprints on the bike or even on the air bike, the reason why, for instance, if you look, let's put it this way, let's put a NIRS sensor on the muscle of focus doing an exercise test versus a NIRS sensor doing a sprint on an air bike versus a normal bike. The desaturation curve on the sprints will be going only down.
Okay.
If you do a resistance training, for instance, do a squat, then it goes down and a little bit up. And it goes down, a little bit up. Because you're almost doing a sprint on the bike, air bike, you have almost an occlusion. You're almost creating a kind of an hypoxia environment in the tissue because the amount of recruitment is so fast and there is no resting phase at all.
Right.
Where with resistance, you have a contraction and then you have to.
And you have a little bit of rest at the top, right?
And then you're opening up, and there's flow again, and then you have a non-flow when you're contracting. With sprints, it's not at all. It's almost kind of a occlusion method, right? That we normally would use also, which also has been seen very effective in hypertrophic. Maybe that's the reason why also sprints can help you out on that kind of way.
Fascinating.
Yeah. I would also argue when you do that more or less looking at the 5, 10, maybe 15 reps or so, you're looking at the more high intensity stuff.
Mm-hmm.
I would always argue for even lowering your intensity, but if you want to go even low, always go for a failure trigger. If there's a need and you have issues potentially for an injury, rather go for 15, 25 and still do failure instead of do high and you have to maintain lower. Right? It's always about that specific failure. I think that kind of triggers the system itself. Kind of combine that specific with your zone 2 training. Because you're with zone 2, I think, when you do a zone 2 training in a day, zone 2 is not your most important thing, but then your resistance training can be. Your zone 2 is kind of your recovery, your kind of go-to modality.
So what kind of zone 2 would you be looking at? So we're RER less than 0.85, right? Between fat max, maybe a little lower than fat max, 10 beats less than fat max, something up to that RER 0.85, that midpoint, somewhere in there. And you stay there for how long? What kind of
good point. I would think, and that's just based on the measurement, you need to be at least 30 seconds because in that 30 seconds there's a lot of noisy data still. There's a lot of changes where the system tries to kind of get into a steady state.
Sure.
I would argue go for the 45 plus, and at least if you can go for the 60-minute, but at least to be at least 45 and up, if you can do that. Yeah.
And how many times a week to build that base?
Again, if you go to 2 or 3 times, 3 I think is best if you can do that. I can imagine there's a lot of time involvement there, right? If you do 3 times. I myself use different modalities to make it kind of fun. So I have my zone 2 modality on the air bike. I have my zone 2 modality on my peloton bike, and I have my zone modality kind of using rocking as a modality when I have 10 pounds on my back or whatever, 10, 20 pounds, not that much, but kind of doing a more brisk run. And again, always using, I'm in the situation where I can use metabolic car data on myself to seeing if the specific number kind of makes sense. And because zone 2 can be, it's not the most interesting. It's a lot of time involvement, so you can do some Netflix stuff or whatever. So make it kind of interesting for yourself, right? But if you do not have there's another thing that I wanted to mention. If you do not have the metabolic card itself, also if you're looking at the NIRS data, if you go back what I said, how I would define zone 2 as a kind of a optimal coupling between utilization versus delivery on the muscle, your ventilation itself, and your cardiac delivery overall to the tissue, the NIRS sensor should not change. So if you have a desaturation change of 0, that's exactly the intensity you need to have. So only with a NIRS sensor on the leg, for instance, you can always kind of already assess or quantify if this is zone 2. If I desaturate a little bit, that means that utilization delivery has a mismatch and I'm not in zone 2 anymore. I'm already looking up to a specific limitation there. It needs to be completely zero.
Okay, so that's we got the zone 2, we got zone 5. I guess if you want to call the sprint work there.
Yep.
So now, if we talk about the 4x4, you mentioned stroke volume there.
Exactly.
Is that the thing that seems to, in the
Yeah,
what we call high intensity effort?
exactly. So the Norwegian method, I think the 4x4. Again, you can go 3x3, even also you can go 5x5 if you want to. I think it depends how you do. I find myself 4 minutes kind of durable, and I created for myself a little bit of a modified version of that. That means again I have all my numbers there. Doing that, that's always of course beneficial. So from the first 3 minutes of the 4 minutes, I need to be around, let's say, 85% of my VO2 max on the VO2 absolute number, right?
Mm-hmm.
The last minute, I'm really going upwards to 95 and 100% of VO2. The
Okay.
reason why that first 3 minutes is kind of your priming your cardiovascular system, mainly priming your heart, because what is happening right now, you have an increased demand, so heart rate goes up. You're going to plateau a little bit on your heart frequency, and the only way for to able to increase delivery is your augmentation of stroke volume. And if you have that and you're really pushing it at the last minute, then you have that specific trigger in stroke volume. You can ask, okay, that's fine, but how do I assess that, right? So there's two ways. If you're looking at your data on your metabolic card, it's called the O2 pulse. O2 pulse means your VO2 divided by heart rate. So what it measures is how many oxygen consumption do I have with one single beat.
Mm-hmm.
If you're going back to the Fick equation, where VO2 is cardiac output, and we know cardiac output is stroke volume multiplied by heart rate multiplied by oxygen EV diff. So if you kind of reorganize that equation and you say VO2 divided by heart rate is the same like stroke volume multiplied by your oxygen EV diff. We know VO2, we know heart rate, we do not know stroke volume, but we have an interesting proxy of extraction. We do not have a oxygen EV diff, mils, whatever there, but we have the NIRS sensor on the muscle that defines if there is an extraction. Is the slope there? And if the O2 pulse is kind of going plateauing or even depressing, and I still have my same extraction ratio on the NIRS is showing an extraction curve, that means there is no muscle issue. The only reason where this number is changing is based on my augmentation of stroke volume. Yeah.
Wow. So the combination of sensors, NIRS, heart rate, and the metabolic data allows you to have insight into that equation to say, okay, well, I know now that the one thing I can't directly measure, stroke volume, I don't have an echo measuring the exact, stroke volume, but now I've limited it. There's only 4 factors. I'm measuring 3 of them. And if those 3 remain the same, or if I'm getting increases in certain ways, then it has to be that 4th factor that's being trained, being augmented by this training protocol.
Yeah.
So when you're doing like a 4x4, I think you said like 3 minutes at 85% of your VO2 max, and that last minute you push a little harder into 95% of VO2 max.
Exactly.
Just to get that stroke volume augmentation, and that addresses that sort of like that specific limitation of if the stroke volume delivery, if the problem is delivery, in other words, this training augments that.
And good question. So going back, so that's the reason why I also use my sensor stack, my sensor data, also on my interventions, because then I can see if my 4x4s, my specific upward slopes on every metric I measure, are all of those 4 the same. And again, if I'm looking at myself, I am specifically also limited on my stroke volume augmentation. So that's my focus point currently. What I need to do is I compare let's say my 4x4, my first training 4x4 2 months ago, compared by my 4x4 I'm doing now, you can see profoundly changes. So my first one was I was doing well in the first 2 of the 4 minutes. The third 4 minutes was kind of I was not able to really increase that's O2 pulse, and the last one was completely off. And now I'm seeing that I'm completely doing every 4 every kind of upward slope from the 4x4 right now is the same. So it's showing that my specific compensation or my adaptiveness during this exercise was done based on my augmentation of stroke volume, but everything stayed the same. Yeah.
Very cool. Okay, so we've talked about muscle training with mitochondrial training, both at the low end with zone 2 and at the high end with sort of sprint work. Both of those are
Yep.
kind of mitochondrial focused in some sense. One is fat optimization. The other one is maximum training.
So yeah, call it mitochondrial biogenesis, right? So you're kind of creating a more efficient mitochondria inside, and because there needs to be a trigger for the system to really change.
With that sprint work, is it you're increasing the density of you're increasing the number of mitochondria per cell, right?
And capillarization also in the muscle.
And capillarization. Okay. Yeah. And then zone 2 is kind of the efficiency of those mitochondria, their ability to burn the fat oxidation. Okay. So then we talked about kind of the 4x4 with stroke volume training, increasing the delivery if that's the restricting factor. So the one we haven't talked about is respiratory training.
Exactly.
Is what kind of breathing limitations do you see, and what can we do about those?
Cool. So all the way going back to our VQ mismatching story, right, where we saw that the V is the most important thing for the ventilation itself and the AA gradient. Interesting enough, of all the stuff that we have discussed right now, there's only one metric that we can influence ourselves directly. We cannot influence mitochondrial function. We cannot influence flow in the muscle. We can influence augmentation of stroke volume or heart rates. Now, heart rate maybe a little bit, but the only thing where we can potentially increase instantly or change is our breathing. In our breathing, our overall minute ventilation is based on the tidal volume multiplied by frequency. So if there is a hyperventilating state, which potentially can have, for instance, the 1 minute allows, that defines that VQ mismatching, that means that you have such a high frequency that the transit time is becoming the more limited version, and you increase eventually. What you then see is you're also expiring a lot of oxygen, so your delta extraction goes low and you're less efficient. So what it means, and then we have our other metric, it's called equivalence of O2 and equivalence of CO2, defined as the VE divided by VCO2 or VE divided by VCO2. That means how many liters do you need to ventilate to consume 1 liter of oxygen, or how many liters do you need to ventilate to get rid of 1 liter of CO2. And that's an important marker. That last one is also a good marker of VQ mismatching dead space ventilation. If you are in an environment when you are more pronounced in the high frequency, so you're eventually only measuring or only ventilating from your chest, from your sternocleidomastoid, from your intercostal, and not specifically for your diaphragm, then you have only an increase in your frequency and a lowering of your tidal volume. What you want to have is, and that only increases transition time or decreases transition time. So if you do it the other way around, if I have my tidal volume high, that means the amount of I can breathe in with one single breath, then I have a lot of time, there's a lot of flow, there's a high amount of volume of flow going to my higher parts of my lower parts of my ventilation, and then I can have that VQ mismatching kind of being less impaired, because I have my ventilation and my flow on the peripheral and the pulmonary blood flow kind of optimized. And how do you do that? You can do that, of course, you can do that in rest, but I think, again, making the case what we saw in our cath lab environment, you need to stress being stressed out to really controlling yourself and how you breathe. So we call it overbreathing or underbreathing, right? So if you are in a resting state and overbreathe, that means you are your frequency is just too high in a resting state, so you're breathing more CO2 out. That means eventually that your P small a, so your arterial CO2 will be lower. If the other way around, and that's the biggest difference, again, I'm going always back to the 1 minute allowed because such a intriguing modality. The most profound effect for 1 minute allowed is we create something is called hypercapnia. We're creating in a time window of 1 minute, you're being hypercapnic. You have a high P, small a CO2, so your arterial pressure in CO2 is very high. And due to your hyperventilation, and if you have a good hyperventilation, that means you can increase your tidal volume very well, and you're matching up that frequency, then you're good. But what happens right now, if you are dysfunctional, so you're underbreathing, you're kind of hyperventilating in a way, that means your tidal volume goes down because you're in that last 20 seconds and you need to somehow compensate. It's the only way for you to compensate to think you need to breathe harder, harder, and harder. But that harder means you're literally overbreathing. You're only airing up only the small parts of your lung. There's a huge amount of dead space eventually and a high VQ mismatching. That will eventually hurt you a lot. And that will only for you to kind of change that is relearn, rethink, retrain yourself in how you need to breathe. And how I do that is kind of combining those modalities that I already have. My sprints and my 4x4s is my recovery is my most important time when I need to make sure my breathing is being controlled. So when I do my 4x4s, again, it's also the reason why I do the 1 minute out so high, because I want to be in my highest respiratory ventilated drive moment. I need those 4 minutes to be ready again for my other 4 minutes. Only way doing so is making sure that my frequency goes down and my tidal volume goes up. So I have dead space ventilation. My ventilation is constantly coupling and kind of compensating for my high CO2 level, so I can get all the stuff out, maintaining my pH, and I'm ready for my next 4 minutes. And what I use right now is I have this thing in front of me. This is called the isocapnic trainer. And isocapnic already means that you are not being hypocapnic, because what normally would happen is if you breathe in very fast, in and out, your CO2 levels will go down. Brain does not like that, so you have a decreased blood flow in your brain, and you can eventually pass out. What they did with this specific device is based on the how the valve works, is that you're also rebreathing some of your own CO2. So you're maintaining the same CO2 levels regardless how fast and how deep you are breathing right now. So this is not a you can also combine this. This is not a resistance trainer, like for instance, this is when you have just a way of pushing resistance during the inspiration. My approach to this is the only way for you to really utilize diaphragm movement is really changing and make yourself very aware of how your diaphragm moves when you're doing a lot of breathing in this way. So I will do this in the recovery phase when I'm doing all the way down. I'm very in an active recovery, and then I'm learning myself to go down, to go down, to go down, and maintain that high tidal volume. It's kind of retraining your motor system in how to breathe again. And the thing is, there's a lot, and it's easier. Let's say it's easier said than done, because it's really, you have to recreate yourself, and it's always kind of, oh, I need to breathe again. And you tend to go very high because that's your easiest way to go by, but you need to go yourself backwards. And of course, what you can do first, just use it in a resting environment to see if you can kind of relearn yourself. How does it feel to be more diaphragmatic? So kind of a belly breathe, that you make sure you're increasing your lung space, and also make sure that you actively put it all down. And that's a way for me to kind of combine those two assessments of two training modalities with this functional breathing. Yeah.
So okay, so just to kind of like make sure I understand, recap the if you're hyperventilating, right? You kind of high frequency, low volume per breath, meaning I'm not taking very big breaths, I'm taking very small breaths, but I'm taking a lot of them. So maybe 25 times a minute, 20 times a minute, but very small amount compared to slow, deep breath that I'm using my full diaphragm, expanding my full lungs, but not very often. Maybe I'm breathing, extreme example, but 5 times a minute, but full big tidal volume. The effective minute ventilation could be the same.
Yep.
But if I'm not using parts of my lung, I'm getting more of that shunting. Blood is passing by lung that has not been aerated, and thus you get the blood passing through but not getting any fresh oxygen, and you get a bit of that shunting, that VQ mismatch effect. And so then you're effectively sending less oxygenated blood somewhat to your body in some sense, right? And with the hyperventilation, you also can exhale more CO2. You're getting rid of too much CO2, and you become slightly hypocapnic, right?
Yeah, exactly.
That combination, I think I've seen some studies, I think, on sort of anxiety being triggered by that combination of hypocapnia and slight hypoxia, relative hypoxia, I would say. So that's an interesting aspect. But then training yourself to breathe deeper, even at rest. Maybe using the isocapnic trainer. I've seen I have the P100, I think, here. But whatever, or just training yourself. Maybe even just free air. You're just practicing breathing bigger and slower to get the same minute ventilation, but just in a different way. Slow volume or slow frequency, high volume. And then you're saying doing the same training under strain by doing it in the immediate post-recovery or the immediate recovery period. So high output, maybe 4x4 or anything like that, and focusing in the recovery moment on as slow as possible, but as deep as possible to retrain that process. And when you train it in that recovery moment, do you see knock-on effects? Do you see people change their breathing methods?
Very
in other ways?
Very rapidly. I think that's also the largest training effect is not doing it in rest. The largest training effect is doing it when it's necessary, and you kind of recondition and reset or reprime your system in knowing that. It takes, I would say it would take maybe 2 or 3 weeks if you do it consistently, doing those tests, doing those interventions, doing the training. But always it's kind of interesting. So you have, I think, the biggest bang for your buck, right? Because you have your 4x4s for your cardiac augmentation stroke volume piece, and you combine it also with your dysfunctional breathing. So you have kind of the best of the both worlds in a very tied down exercise intervention. Wow. Yeah.
Okay, so I mean, we've kind of I want to cover the brain last, but we've covered muscle utilization, both in terms of mitochondrial efficiency in zone 2, mitochondrial genesis and capillarization with what I call zone 5 or the sprint work, right? For addressing problems with the limitation at the muscle. We've addressed kind of the problems with delivery of flow, stroke volume augmentation with the 4x4 type training.
Right.
And now we've addressed respiratory limitations by addressing that during recovery, slower but deeper breaths to hit the same minute ventilation, but in a more optimum way, less dead space, less VQ mismatching, and less hypocapnia.
Exactly.
Are there any other limitations in the body before we move on to the brain?
No. I think those are the major ones.
Those are the main ones.
Yeah. But you can also change very easily. Right. Yeah.
All right. So then moving on to the brain, I know I was very intrigued. I hadn't heard of this before we started talking. Looking at changes in brain blood flow. You mentioned the prefrontal cortex with the NIRS device in the head. Attributed to cognitive functioning, attributed to metabolism in the brain.
No, good point. So I'm not a neuro expert somehow, but my main interest is still like mitochondrial respiration, right? And one of the most profound high dense mitochondrial organs is still the brain. So, and if you kind of couple, and that's the reason why we kind of got there from a perspective of readiness. So we do in our lab also a lot of work with special force operators. So if you have a guy that needs to do a clearing from a room, we were thinking, how does being fit also correlate with acute decision making, so executive decision skills? So, and you can also easily kind of translate that to sports. So if you're looking at a basketball player who has done multiple sprints and he's there and he needs to do that 3-pointer, is that Does it need to do it now? Are there motor skills there? Do I need to pass the ball to someone else? There's a lot of cognitive executive functions going around to make sure that it's not based on how fast he was doing the sprint. A lot of stuff that's combined. So the reason why I think is such a powerful coupling of VO2, brain, so VO2, hands, lung, muscle, heart, and also brain, is all the stuff that we talked about is mainly looking at CO2 levels. So the cerebral blood flow is very much influenced by your CO2 levels in your arterial blood. So normal levels, we call that normocapnic, right? If you have lower levels, we know that hypocapnic. If you have higher levels, it's hypercapnic. And hypercapnic means that you do not get rid of all the CO2. So in that 1 minute allowed is mainly a hypercapnic event. So that means you cannot, because the time is too short and you have a lot of ventilation and you cannot get that CO2 out because you're potentially dysfunctioning your breathing and stuff, and you cannot get rid of that specific CO2 levels. That creates a very high increase in cerebral blood flow. So you have a high increase in your brain. Stay to that. Let's go back to the other ones. Normal is what we normally would have. That is fine. If you have a hypocapnic event, like you're a little bit in an anxiety state, you're constantly over-breathing yourself. So instead of having 12 breaths a minute, you're looking at 20, 25 with a very shallow breath. So you're looking at tidal volumes maybe of 200 liters or so, whatever, 150 milliliters or so. Then you have another way around. That low CO2 levels, because you're constantly more breathing out than breathing in, will create a lower cerebral blood flow. Both the high flow and the low flow will have kind of the same effects in regard to executive function. The brain does not like the extremes of high flow, low flow. There's a kind of a sweet spot where it needs to be kind of matching delivery and utilization on the level of the prefrontal cortex. So we were arguing, of course, it's tough to measure, but we have now the NIRS where we can measuring the deoxyglobin kinetics, and where oxyhemoglobin is by far the best biomarker of activation of the prefrontal cortex. What we did in a T1 special force unit, we did a 1 minute allow test, and then we created a flow to a close quarter battle drill where they need to clear up rooms to see could they make in a high
like a kill box type scenario. They're going room by room shooting at targets, right?
Targets, exactly. So what we did was we did first of all, of course, without the 1 minute allowed, and then I created a hypercapnic event. So what I did was I created a huge amount of flow in the brain, like they would, for instance, sprint to a house and need to be ready to clear that house. Thus, their breathing skills or non-skills, because they did not train them at all, have influence on their brain function, the flow. We measured their cognitive decision making with the Simon test that we have in our app, and also saw were they able to make the right decisions, because if they were clearing the rooms, we created the targets based on coloring and patterns on the target itself to see if this was a hostage or this was the bad guy who they need to shoot with. And if there was a bad guy they need to shoot with, they needed to have the SOP was 4 shots in the chest to make sure that the grouping of the shots were very much aligned constantly. So we had a lot of functional outcomes to see. So we have the brain, we have the breath, frequency stuff, and what we saw was that if you put them in the normal flow, so for them doing a CQB is there's the comfortable level, right? That's what they do always. So if you get them into a room doing that stuff, they almost don't need to think about what they do. But I think that's where the details are always there, right? When the difference are very small when you are going to a flow state and that your executive function is not always ready. Your situational awareness of stuff, because you're doing it so much. But when I changed that situational awareness, because I did that specific 1 minute allowed, it all changed. And we saw specifically people who are, and they were all are, unable to maintain that functional breathing kinetics. Again, if you're only going up, only in your frequency, you get that CO2 out, so there's a lot of flow into your brain. Brain does not like that. You create a situational awareness that can be foggy, you are not that fast anymore. So if you need to do a clearing of a room or make the decision on putting the trigger yes or no, you're much impaired. And that's what we saw. So then kind of the whole physiology of VO2, limitations, how do you define specific your breath kinetics based on frequency versus tidal volume, and then also looking at how the brain kind of responds to that specific trigger was very profound and also an eye-opener for everyone there involved. Yeah.
That's fascinating. I mean, it just personal reflection on some level. I remember in residency, I read Malcolm Gladwell's book. I think it was Blink at that time. And one of the things he talked about is an effect observed at that time in police, that when they were chasing, when they were running, they lost the ability to distinguish facial expressions. Is this an aggressive facial expression, or is this a fearful facial expression? And because once the heart rate gets over a certain point, and in this case, maybe there was proxy for hypercapnia, probably they didn't measure, obviously, then they lost the distinguishment, and shootings happened when the person wasn't armed, when the person, was actually backing off, was, whatever, but that their brain had shut off. Right. And so a similar effect here, kind of seeing, I remember in residency, we did these drills to train how we run Code Blue. So Code Blue is called, and in the training, in the simulation, we do it in a room. We do it with the mannequin and whatever, X, Y, and Z. And one of the things after reading that book that I noticed is, wait, when it happens in the hospital, we have to run to the room. And that changes the entire experience. And so I started practicing running sprints in the hall before I would go into the simulation room to simulate the physiology and train that process under similar conditions. It's interesting to hear that there's a physiologic basis for this sort of experience.
Yeah. And right now, I think there is also, so what they got out of that, of course, again, for them is then the same. Your VO2 max is kind of your base on be able to maintain and being efficient, right? So we have them also in a part of an intervention. So how do you specifically train yourself? How do you do that? The breathing techniques. From a special operating force operator, what I want to do is try to see how can I be comfortable in the most uncomfortable situation ever. What I need to do. If I know that, if I'm aware of that, how can I kind of control myself and be sure that I'm able to maintain that specific readiness level? And that's the thing, that's an education piece. That's not only about science, but it's also, of course, need to have that sensor stack to have this specific measurements done. And I think it's also a mindset change, right? We need to be more aware of, it's not only pulling the trigger and being fast on this, but breathing and there's a lot of stuff there what you need to do and what you can do if you're aware of that right now. And there's a lot of right now I would say openness in this community to know more, to learn more.
Well, they're performance oriented, if nothing else. That's a very a very performance driven. If anything can give them an edge, they'll take it.
Yeah.
So let me take that in a different direction. One of the things we see a lot with long COVID, going back to that kind of physiology, is brain fog as a descriptor of difficulty. Makes me wonder if we're seeing mitochondrial on a muscle level, mitochondrial dysfunction. Is there mitochondrial? If the brain is so full of mitochondria, is there also mitochondrial dysfunction at a brain level?
Cool point. Yeah, I think definitely. Yeah, I think there is. Also, if you're looking at a perspective of muscle. The muscle is one of our largest metabolic organs. So the inter-organ crosstalk from organ, muscle versus gut versus brain is very distinct. You can imagine if the brain is kind of also following up on specific signals of the muscle and it knows how to kind of regulate itself. And now the muscle is not shouting anymore, is not doing anymore. It's silent.
Mm-hmm.
So how can that be the case? There is no inter-organ crosstalk anymore. So that can have profound effects on. That's also, I think, the reason why, for instance, Alzheimer or any specifically mind health, brain health thing has always a correlation with overall fitness.
Hmm.
It's not that the brain is better. I think there's a profound kind of relation how the inter-organ crosstalk from the muscle all the way to interleukins and cytokines and stuff, how that really defines the regulation of the brain itself. Yeah.
That kind of takes me back to our previous example of heart failure, where maybe the original issue is heart, and then after time you end up with mitochondrial dysfunction at the muscle. Now, this is almost the same thing in reverse. You have mitochondrial dysfunction in the muscle and can cause dysfunction elsewhere,
Exactly.
mitochondrial function in the brain, or maybe, who knows, gut, wherever else.
Yeah,
That
absolutely.
could be. Now, have you ever, I mean, I'm just throwing this out there because I have no one else to ask. Have you seen any studies on improving mitochondrial density or capillarization in the muscle leading to changes in brain oxygen usage?
No, I think there's not that I know of as of now.
Okay.
That's one of the things that we're still looking in here from at Duke.
Okay.
What we still know, and that's one of the, again, it's anecdotal because we don't have that much of data as of yet, but potentially if you have a patient going for major elective surgery, one of the most, I think, the worst complications you can have after surgery is delirium, right?
Mm-hmm.
So the reason why it's kind of the question is, why do you get delirium after surgery? What is the trigger of that specific brain dysfunction, which can be pretty horrific and pretty has
Very
and
problematic.
huge consequences for the patient itself and also for the family, of course. Is what we saw was, and I think that potentially can be a proxy. If you do that exercise test on elderly, and you see, also using the sensor on the NIRS sensor on the front of the head, if there is almost a non-signaling, so there's no utilization at all, that can be potentially a predictive measurement. Because what we're doing is we're putting the brain in a high respiratory, in a high flow state, and kind of already stressing it out and see, okay, we're going to stress you out right now and see how you do.
Mm-hmm.
And it's kind of comparative with that surgical stress or the post-surgical stress when they are entering the floor or the ICU, when you have such an inflammation state and the brain somehow needs to kind of work with that, right? And the reason why, I think, going back to the heart failure, if you have a profound mitochondrial dysfunction in the brain, you will not see that in rest. You can be in heart failure and rest, you don't see that.
Right.
You need to stress the system to see the signals. And that's the same way I think about how the brain works, and where potentially an exercise test can be a prediction tool to see if someone is more prone for a delirium after surgery, of making that specific correlation there. Yeah.
This is a theme that we keep coming back to in this conversation that I maybe wasn't as attuned to. Is we do all these tests in medicine. You go to a DEXA, you lie down. You go to a CT, coronary calcium score, you lie down. All of these tests are at rest, maybe with the exception of an exercise treadmill stress test, right?
Yep.
And even then you're really only looking at changes in cardiac output under echo, right? Or Lexi or whatever.
Yeah.
But one of the benefits of the VO2 and plus the NIRS plus the heart rate, this combination of data that Splendo is able to integrate is you get a picture of what's happening under conditions of stress, which you're stress testing, not just a stress test of the heart or the coronary flow, which is the only stress test that we really do commonly. You're doing a stress test of so many different metabolic systems, respiratory systems, brain flow, brain oxygen utilization, all of these different, in addition, of course, to delivery, of course, as well, cardiac delivery. And it is, VO2 max is very predictive, the VE over VE over VCO2 ratio slope, very predictive of ischemia as well. So it's not like we're not getting cardiac data, but in this data set, it's so rich for information on all these different bodily systems, and maybe going back to, because of the stress, because of it's under conditions of stress.
It's the most profound trigger. You need to have some kind of a priming of the system to see if the system is unable to compensate for the demand. Exactly.
And that goes back even to what you were saying before, is that flexibility demonstrating that flexibility demonstrates sort of their predictive capacity for withstanding, being resilient to, at least in your case, COVID or illness, but potentially even longevity. I mean, I haven't personally seen any data. I'd be curious on data to see sort of zone 2 with or fat max both, and the correlation with mortality. Just as this study
no,
did with
absolutely.
VO2 Max.
Yeah, I think eventually, so that's one of the things I'm kind of looking for, to see if we can kind of set up a multi-center kind of a longitudinal study where we can assess all those data that we collect from Spender Health itself, from the system, and do multiple tests in a year on people, right?
Yeah.
One of the things that I still want to do is, for instance, a good example is, can we give a subcohort of elderly, like 65 plus, the full sensor stack for a year, and they do bi-weekly, for instance, a submaximal test, and we see, based on the changes, do we see some predictions? Is there normal fluctuations? You don't have, let's say HRV, you have high and low, a little bit of what you do and not do. It's the same thing on your VO2. And do we see also, if we, it would be even cooler if we do multiple years, then we can see potentially also mortality numbers and all outcome stuff. But do we have a better understanding about how this physiology really works, and how do they change? And I think that's huge. And also from a decentralized way of looking at rehabilitation, where I think the biggest issue we currently have with cardiac rehab, for instance, is also non-responding. And I think the reason why we're non-responding is that, we just do the same thing over and over again, right? We don't have
training the wrong system. If we're, I mean, if it's,
it doesn't work at all. You need to kind of really trigger that, really kind of tailor that specific system there. Yeah.
That'd be fascinating. If cardiac rehab is training, delivery, the cardiac output, and the person has a mitochondrial dysfunction at muscle utilization issue, well, you're not going to get anywhere. Right?
Yeah. No, absolutely.
That's fascinating. I mean, amazing discussion. I don't know if there's anything else we missed, anything you want to talk about with Splendo or directions, or we've covered a lot of territory here, but
we have a lot of, I'm not sure if people, of course, this is what the,
maybe just go. So that's the Caliber device. I did a podcast previously with Udi, the founder. But taking this technology and making it widely available, and not just for doctors, I guess, hopefully, although maybe data interpretation does require some physiologic understanding, but at least data gathering can be done,
very
as
easily.
You said, distributed.
Yeah. Now, good point. So what we are working on a kind of an AI model on the kind of interpretation of the reports itself, to kind of going back, we have a kind of a flow analytics pathway where, how do you kind of look into this data and have a very easy way of understanding the physiology. And one of the questions will be kind of how you go through the flow. Is this a submax or a max test? What are the limitations? Is it more dysfunctional breathing? Is it more cardiac? Is it more mitochondrial? Where they need to be, and what can you potentially kind of advise or guide them specifically on their interventions? Yeah.
Phenomenal. Well, I appreciate your time. Amazing conversation. Amazing deep dive into VO2 Max.
Thank you, man. Appreciate it.
Appreciate it.
Yeah.
Thanks.